Hanji, good evening everyone. So first of all, tell me, am I audible? Am I visible? Everything clear? Can you hear me? Then we'll continue, then we'll start our discussion. Everything fine? Audio visual okay? Hanji, good evening everyone. Okay, so yeah. No, it's not. So I guess I'm visible to you. Everything fine? Saf, Vinod, Anil. Yeah. So good evening, all of you. And Saf has said and Vinod has said everything fine. Let's start. Dekho. FMGE, the level has become little higher what it was 10 years back. 10 years back, the questions were very simple, one-liner, straightforward. Now they don't ask. They do ask one-liner, but rarely. They ask more of a clinical question, image-based question, approach-based question. Now, this is a very simple question. I'm sure all of you can answer. This topic is not important. This is DES, diffuse esophageal spasm. This condition, this image is known as Cox-2 appearance. तो ये फोटो इतनी इंपॉर्टेंट, मतलब टॉपिक इंपॉर्टेंट नहीं है, खाली ये फोटो आती है. ओनली दे आस्क दिस फोटो एंड आस्क यू कि क्या है, व्हाट इज दिस Cox-2 appearance. So there are certain conditions in esophagus where they do ask image-based question. So I'll tell you some of them. First of all, DES is a motility disorder common in middle-aged female and treated usually medically. Calcium channel blocker is the main drug, but sometimes we go for long myotomy. And dysphagia and pain. Unlike achalasia where you only have dysphagia, here we have dysphagia and pain both. So this is one image. I'll show you a few more images because this is another image that you get very often, a barium swallow image showing a outpouching posteriorly. Now can you tell me what is this condition? Another minor topic but very important topic, very frequently asked in your exam, PG entrance as well as FMGE both. So can you tell me what this condition is quickly? Okay, so this condition is Zenker's diverticulum. And what is Zenker's diverticulum? You see, this is the cervical, yeah, Tohin is absolutely correct. This is cervical esophagus, the गले वाला part of esophagus. और नहीं, ये atresia नहीं है साफ, इसको Zenker कहते हैं. साफ, listen carefully what I'm saying. ये old age में होता है. This is a condition of old age, and atresia you get in children, young age, neonatal age. This is Zenker. देखो क्या होता है. ये गले का esophagus है ना. यहाँ पे दो मसल होते हैं, two muscle. This is oblique muscle called thyropharyngeus. And this is horizontal muscle called cricopharyngeus. So there are two muscles, thyro and cricopharyngeus. In between these two muscles, this triangular area is a weak area called Killian's dehiscence, as many of you have rightly written. Saf has Killian's dehiscence. Okay. So ये जो Killian's dehiscence है, if this sphincter, which is ये muscle cricopharyngeus acts like a sphincter, if it doesn't open, तो प्रेशर बढ़ता है और यहां से आउटपाउचिंग हो जाती है. दिस इज कॉल्ड Zenker diverticulum. सी हियर, दिस इज ए FMGE 2021 क्वेश्चन. Killian dehiscence किस मसल के बीच में होता है? इट इज इन बिटवीन थायरो एंड क्रिकोफेंजियस मसल. दिस स्पेस इज कॉल्ड Killian dehiscence. और यहां पे प्रेशर इज हाई. द प्रेशर, द स्फिंक्टर, विच मसल? दिस मसल, क्रिकोफेरेंस. इट फेल्स टू रिलैक्स. Pressure from inside, outpouching here, forming a diverticulum called Zenker diverticulum. So this is a X-ray of Zenker diverticulum, quite an important X-ray for your exam. Presents with dysphagia and regurgitation. Barium is investigation of choice and treated by diverticulectomy and cricopharyngomyotomy. क्या करते हैं? ये डायवर्टिकुलम काट के निकाल देते हैं. This is called diverticulectomy, पहला काम, where I cut and remove the diverticulum, plus cricopharyngomyotomy. This muscle, I'll show you. This muscle is simply cut. ये वाली जो muscle है ना, इसको काट देते हैं like this. This is the muscle which has been cut open. Second is Dolman's procedure, Dolmann, which is an endoscopic procedure, not commonly done, but the name you should remember, it's MCQ. Dolman operation is done for what? This is done for Zenker. Another image of barium is this one. A very, very important image in esophageal pathology for you. And I'm sure all of you can identify this condition. This is bird beak sign. Where do you get this? Achalasia cardia. Agar ye lamba hai, if this is long, then we call it rat tail sign. Rat tail, although more often we get in cancer, but sometimes in achalasia you can get rat tail. Agar ye chota hai, to ye bird beak kehata. You get in achalasia cardia. What is achalasia cardia? Ye dhyan se sunna. Failure of relaxation of LES, lower esophageal sphincter, due to absence of AUERBACH, Orobec ya Minteric plexus. Both are same in the muscle. So we do have one more plexus in esophagus or in the GIT called Meissner's plexus. So this is a very commonly asked question. Meissner's plexus are not involved in achalasia. Only Orobec plexus are involved. Or isme bhi sirf inhibitory fibers are involved. So only Orobec inhibitory fibers are involved in achalasia. And common in young age. Barium shows bird beak sign, and what is the gold standard investigation? Manometry. So gold standard manometry, barium shows bird beak sign. Treatment is myotomy, Heller's myotomy, HELLER, Heller's myotomy. और दूसरा treatment है which is endoscopic, POEM, per oral endoscopic myotomy. Yeah, rat tail sign you do get in cancer. But here also, rarely you may get rat tail sign, rarely. So rat tail sign you get in both. If I ask you in which condition you get rat tail sign and you have to answer one, so as you have rightly written, it is cancer. Agar ek hi jawab dena to cancer zyada acha jawab hai. But in achalasia also you may get rat tail sign. So treatment is Heller's myotomy or POEM, per oral endoscopic myotomy. Okay. Now this is another, dekho, normally what happens? Esophagus and stomach are like this. When this junction goes up, this is called sliding hiatus hernia, and when only fundus goes up, this is called rolling hiatus hernia. So hiatus hernia is a condition. This is the diaphragm, this is the esophagus, and this is the hiatus of diaphragm at the level of T10 through which esophagus passes. And through this hiatus, if this thing goes up, we call it hiatus. This thing means stomach goes up, we call it hiatus hernia. Sliding hiatus hernia is more than 90%, rolling is 5%. So when GE junction goes up, it's sliding. When only fundus goes up, G junction below diaphragm, this is rolling. Rolling is also called paraesophageal hiatus hernia. So these two X-ray also you need to identify. ये भी बहुत important तो नहीं है, लेकिन पूछा जाता है. This also they do ask. You see, the stomach pouch has gone up, G junction is here, and this is another picture where the fundus has gone up and G junction here. So sliding and rolling hiatus hernia are other two important X-rays in esophagus you need to remember. देखो, sliding hernia presents with reflux and generally treated conservatively, while rolling presents with dysphagia, volvulus, gangrene. So rolling surgery always done, sliding surgery rarely done. और रोलिंग में जो अल्सर बन जाता है फंडस पे, वी कॉल देम कैमेरॉन अल्सर. सो रोलिंग कैन हैव कैमेरॉन अल्सर एज वेल. इन स्लाइडिंग देयर इज no tear in the ligament. This is called ligament. This red line is the phrenoesophageal ligament. Phrenoesophageal ligament. No tear while in rolling. There is a tear in the ligament. So these are the main features about sliding and rolling hiatus hernia which you need to remember. Okay, so these are some minor topic of esophagus which they give as a image based question. Okay, sliding and rolling hiatus hernia, achalasia cardia, which I am sure you can identify bird beak sign, Zenker diverticulum, corkscrew appearance. These are the common. Yeah, rolling is not really an emergency, but it can present as emergency and should be always treated surgically. It is more likely to have complications of valvulus gangrene, etc. So rolling should be operated upon, while sliding can be managed conservatively. So these are some topics of. Now, can you tell me the answer of this question? A patient underwent total gastrectomy. Which of the following deficiencies would be seen in this patient? So I'll wait for 1 minute because there's a lag. When I speak something, it reaches to it's about 30-second lag. So I'll wait for some seconds for you to answer. Can you answer this question? B12, B1C, A. Yes, very good. Saf, Knox, you both are right. Tuhin, Hemant, Parth, Yamini. Good. Yeah, you see, few complications after gastrectomy we need to know. The first complication is, this is the earliest complication, loss of reservoir. This is the earliest complication. Okay, loss of reservoir. Second is iron deficiency anemia. This I would say is most common nutritional deficiency after gastrectomy. And what is the reason? The reason is the iron is absorbed from duodenum. ये याद रखना, ये पूछा जाता है. 90% iron is absorbed from duodenum, 10% absorbed from jejunum. Iron doesn't go to ileum, ये duodenum से absorb हो जाता है. So 90% is absorbed from duodenum, but it gets absorbed when it gets converted from ferric to ferrous form. और ये ion change कौन करता है? Acid. So we need gastric acid for the ion change of iron from ferric to ferrous form. Then it gets absorbed. Because of acid deficiency, there is no ion change. Iron deficiency anemia is a very, very common problem of gastrectomy. Second complication that you get is B12 deficiency anemia. Why? B12 is absorbed from terminal ileum and it is absorbed when it gets combined with intrinsic factor. And where intrinsic factor being produced, with cell producing, it is produced in the stomach by parietal cell, the same cell which produces HCl. So it is produced by stomach. Although B12 is not absorbed from the stomach, but it needs intrinsic factor to get combined and get absorbed. Because of deficiency of intrinsic factor, B12 deficiency anemia is very common after gastrectomy. This was a last year INICT question, that dissection, removal of which part of GIT will not lead to B12 deficiency? Stomach, duodenum, jejunum, ileum. So stomach is required because it produces intrinsic factor. Ileum is required because from there it's absorbed. Sometimes B12 is combined with the protein and that proteolysis is done by duodenum, so that's also required. Jejunum has no contribution, no role in B12 absorption. So jejunum resection will not affect B12. And this is another old FMGE question, that patient had undergone gastrectomy. Now she is having beefy tongue. See the tongue, shiny glossy tongue, no papilla. Out of these four, which deficiency is this? This is B12 deficiency. This is another old question. So B12 deficiency anemia you get due to intrinsic factor. Other than this, rarely calcium deficiency, steatorrhea you get due to acid deficiency, and dumping syndrome also is another problem of gastrectomy. Dumping means the food rapidly goes into the small intestine, causing osmotic diarrhea, and later on hypoglycemia. Later on hypoglycemia. So These are some complication of gastrectomy you need to know. Out of these 4, this is obviously the right answer, as most of you has written. Now, this is again a very important X-ray for all of you. ये आपसे बहुत ही frequently पूछा जाता है, बहुत frequently. And yes, if you have attended DVT, then most of the topic are same, but obviously here I'll be discussing urology as well. I did not discuss urology in DVT. So urology second part I'll discuss. देखो, ये air below diaphragm suggests hollow viscous perforation, and it should immediately be treated by resuscitation followed by laparotomy. Now, this is a very important X-ray. आपसे पूछा जाएगा क्या है ये? Perforation peritonitis है, और आप सीधा laparotomy नहीं करेंगे. First you do resuscitation. Now you see these are 2 more X-rays showing hollow viscous perforation, and one more sign I want you to show you, which is a pneumoperitoneum sign. You can see wall of the bowel, which normally is not visible. This is called Wriggler sign. Wriggler sign is another, like here. You can see the wall of the bowel. These white lines are. This is another potential MCQ. And third thing I want you to remember, Wriggler triad, which is a triad of gallstone ileus, where you have stone in ileum, air in gallbladder, and obstruction, dilated bowel loop. So, stone in ileum, pneumobilia, obstruction, this is called Wriggler triad, which is a triad of gallstone ileus, while Wriggler sign is a sign of pneumoperitoneum. And this air below diaphragm is a very important X-ray. ये आप skip miss नहीं कर सकते हो, ये एग्जाम में बहुत पूछा जाता है. One more point I want to tell you, देखो, मान लो this is the liver here, this is the stomach, this is the colon, and a perforation takes place. The air goes out, gets collected here. So whenever you find air below diaphragm, by default we consider this is pneumoperitoneum perforation. But in some people, the colon goes like this. This is the colon going like this. So now if I find air below diaphragm, that is not free air, that is inside the colon. This is called Chilaiditi syndrome, which is MCQ. So Chilaiditi syndrome is basically what? I will find air below between the liver and diaphragm. That's the bowel loops. Interposition of bowel between liver and diaphragm is called Chilaiditi syndrome or pseudo-pneumoperitoneum. ये भी आपसे ये, this air is not air below diaphragm, this is colon. तो ये भी आपसे पूछा जा चुका है, और ये कभी-कभी ये कम इंपॉर्टेंट है बट पूछते हैं. They do ask what is Chilaiditi syndrome. So Chilaiditi syndrome is simply air below diaphragm, which is not free air, it's inside the bowel loop. Okay, that's another question they ask. So Chilaiditi syndrome, Wriggler triad, Wriggler sign. Wriggler sign is less important, of course, and air below diaphragm. These are very common, important point you need to remember about pneumoperitoneum. Now, tell me the question of this, answer of this question. 35-year-old male with gastric outlet obstruction. Yeah, Chilaiditi sign is just finding the colon there, air there, and when there's obstruction or pain, we call it Chilaiditi syndrome. So, what is the answer of this question? Yes. देखो, whenever there is GIT loss from the small intestine, then there is acidosis due to the loss of bicarbonate. So, in small intestine loss or colonic loss, Ringer lactate is the fluid of choice in small intestine loss. But in stomach loss, there is alkalosis, and Ringer lactate will increase the alkalosis. So we prefer normal saline. So whenever there's a gastric loss causing alkalosis, normal saline is preferred because there's a gastric outlet obstruction, which is why normal saline is the best fluid. Dextrose is not really required. Dextrose you can give, but in children, in neonates, dextrose needs to be given because their calorie reserve only lasts for 12 hours. But in adult, if I don't give anything by mouth, patient will not have calorie problem for 4-5 days. We have enough store in glycogen and fat in our liver, muscle and subcutaneous fat. There's no problem. So we can just give saline. You can give 5% dextrose, 1 bottle in a day or 2 bottles, but that really gives 90 kilocalories, not very important. So dextrose is okay, fine, one can give, but not necessary. Normal saline is the best fluid. Ringer lactate should be avoided, not contraindicated, but should be avoided because this will increase alkalosis. But in case the question says small intestine loss, like not just gastric outlet obstruction, there's a fistula, ileal fistula, an excessive high output fistula, then ringer lactate is the best solution. If I only give dextrose, then of course I'm not giving any electrolyte, plus dextrose has osmolarity of 255, blood has osmolarity of 290, so it's hypoosmolar, it will cause hyponatremia also. So I'm repeating what I said. In stomach, there is acid loss, so there is alkalosis, and ringer lactate will increase the alkalosis. So normal saline is preferred. While in intestine, normal saline is the ringer can be given because there is acidosis. Okay? Are you following what I'm saying? 5% dextrose is not needed in adult for a day or two. We can give, but not needed. In children, we give because there is no store in the body for calories. An adult male presented with symptoms of duodenal ulcer. I would like you to answer this question because this sawal FMGE normally I don't teach, so I rarely see the question which has been asked. This question has already been asked, and I saw an online lecture where the wrong answer was given. So I just want you to answer this question. Let's see how many of you can answer this. Yeah, the right answer is gastrojejunostomy. Let me quickly tell you the concept of ulcer disease. It will hardly take 5 minutes, but it will help you. Yeah, Seth, which is why I said, because in online lecture I was just trying to get the idea what kind of question being asked in FMG. So I saw that the faculty which showed this question, he gave the answer as HSV, highly selective acute, which is wrong. So let me explain. Dekho, just remain focused for 2 minutes, 5 minutes, and you'll understand the concept of ulcer. देखो दो तरह के अल्सर होते हैं. Gastric ulcer is due to decreased resistance, not due to more acid. Duodenal ulcer is due to high acid output. Anything, gastrinoma, spices, alcohol, anything. There's that H. pylori causing more gastrin, they call duodenal ulcer. So gastric ulcer, what is the most common site of gastric ulcer? Here. Lesser curvature, incisura, here. And gastric ulcer is treated by generally, surgically, gastrectomy. Preferably Billroth 1 or rarely Billroth 2, more often 1. So gastric ulcer is treated by gastrectomy. Remove this part of the stomach which is having ulcer. While duodenal ulcer is suppression of acid, proton pump inhibitor or H. pylori eradication. Surgically, what treatment we do? In the past, just gastrojejunostomy was done like this. So this acid, when goes to duodenum, causes ulcer. Now the acid will simply go into the jejunum, will not go into the duodenum. So there's no problem. Okay, and this will relieve the ulcer, but the recurrence of this surgery is more than 50%. So just GJ, I'll repeat, देखो ये स्टमक है, ये डिडनम है, एसिड यहां से यहां जाके अल्सर कर रहा है. What if I do a gastrojejunostomy, मैं खाने को यहीं से बाईपास कर दूं तो क्या होगा? The acid will simply go from here to here, यहां पे जाएगा नहीं, अल्सर ठीक हो जाएगा. So GJ was the first surgery done 100 years back for duodenal ulcer, and people were surprised when they found that ulcer got healed. So ulcer ठीक हो गया, लेकिन recurrence is very high. So GJ has a very, very high recurrence, 50%. So this alone is no treatment anymore. So what we do, we go for proton pump inhibitor. लेकिन अगर सर्जरी करनी है तो क्या करेंगे? हम करेंगे वेगोटमी. Why vagotomy? Vagus is parasympathetic cholinergic. ये एसिड बनना बंद कर देगा. Now, vagotomy, there are 3 types of vagotomy: truncal, selective, and highly selective. Truncal का advantage ये है कि it has least recurrence. This is the advantage. But it has complication of gallstones and post-vagotomy diarrhea. So truncal has least recurrence, which is why nowadays we only do truncal if required. पहले तो सर्जरी करते नहीं, करेंगे तो ट्रंकल ही करते हैं. Gallstone and post-vagotomy diarrhea. While selective do not have these problems of gallstone and post-vagotomy diarrhea, but has a problem of higher recurrence. Highly selective has highest recurrence among these 3, but least side effect. इसमें side effect की बहुत कम chances है. Drainage नहीं करना पड़ता है. I'll repeat. So gastric ulcer is treated by gastrectomy, preferably Billroth 1, rarely Billroth 2, while duodenal ulcer is treated by suppression of acid PPIs. If surgery needs to be done, GJ alone is not done anymore. It causes 50% recurrence. Gastrojejunostomy. So we do vagotomy to suppress the acid. Truncal is the only vagotomy now we do. Selective is obsolete. Highly selective, rarely done. So what problem truncal and selective has? Truncal and selective अगर आप कर रहे हैं तो आपको ड्रेनेज करना पड़ता है. यू हैव टू डू ड्रेनेज प्रोसीजर, एंड ड्रेनेज मीन्स आइदर गैस्ट्रोजेजुनोस्टमी और पाइलोरोप्लास्टी और एंटेरेक्टमी. And drainage has its own side effect, lots and lots of side effect, which is why we avoid this, but this is the only option you have if PPI doesn't work. So now and another question, which surgery has least recurrence? Truncal, vagotomy and enterectomy. This has least recurrence. So I'll repeat what I said. I said that gastric ulcer and duodenal ulcer are different etiology. Gastric ulcer is due to not acid is not being produced more. It is due to decreased mucosal barrier mechanism. Mucosa की ताकत कम हो गई, बाइकार्बोनेट, थिकनेस, ये सब कम हो गया. प्रोस्टाग्लैंडिन इससे बनता है, ये प्रोटेक्शन होता है, प्रोटेक्शन कम होने से होता है. सो गैस्ट्रिक अल्सर ड्यू टू डिक्रीज रेजिस्टेंस, treated by gastrectomy, which is common in the lesser curvature incisura. Duodenal ulcer is due to more acid production, treated by acid suppression. First part duodenum में होता है. Acid suppression done by PPIs, proton pump inhibitors. If surgery required, then we have vagotomy. Vagotomy में truncal vagotomy has the least recurrence along with drainage, either GJ or pyroplasty or enterectomy. Truncal vagotomy and enterectomy has the least recurrence rate, but side effect इनके सबसे ज्यादा हैं, इसीलिए हम इसको अवॉइड करते हैं. Selective is obsolete, वो खत्म हो गया. मैं ड्रॉ करके भी समझा देता हूं जिससे आप शायद थोड़ा ज्यादा समझ जाओ. देखो ये स्टमक है, ये है एंटीरियर वेगस, ये हेपाटिक ब्रांच जो लिवर को जा रही है, गॉलब्लैडर को जा रही है, ये पोस्टीरियर वेगस, ये सीलिक ब्रांच, और ये पैराइटल सेल जो एसिड बना रही है, ये पाइलोरस की ब्रांचेस. सो अगर मैं यहां से काटता हूं इस जगह से, इसे कहते हैं ट्रंकल. ऑल ब्रांचेस गॉन, हेपाटिक ब्रांच गॉन, सीलिक ब्रांच गॉन. अगर मैं यहां से काटता हूं, इसे कहते हैं सेलेक्टिव, बिकॉज आई एम प्रिजर्विंग द हेपेटिक सिग्नल बट हैज ए हायर रिकरेंस। और अगर सिर्फ ब्रांचेस इनकी काटता हूं तो इसे कहते हैं हाईली सेलेक्टिव। या वेगोटमी कर सकते हैं गैस्ट्रिक अल्सर के लिए, करते भी हैं, बट वेगोटमी का रोल इसलिए नहीं है क्योंकि गैस्ट्रिक अल्सर एसिड से नहीं होता। वेगोटमी विल डिक्रीज द एसिड प्रोडक्शन एंड गैस्ट्रिक अल्सर नॉट ड्यू टू एसिड, सो इट हैज वेरी लिमिटेड रोल। नाउ कैन यू टेल मी द आंसर ऑफ दिस क्वेश्चन? ए लेडी, सो आई होप यू अंडरस्टूड द क्वेश्चन। अगर मैं कहता हूं वेगोटमी में सबसे ज्यादा रिकरेंस किसकी है, विच वेगोटमी हैज द हाईएस्ट रिकरेंस, तो हम बोलेंगे हाईली सेलेक्टिव वेगोटमी। बट इफ आई से ओवरऑल सबसे ज्यादा रिकरेंस किसकी है, विच इज द हाईएस्ट रिकरेंस इन ऑल सर्जरी, तो हम जवाब देंगे गैस्ट्रोजेजुनोस्टमी, GJ। A lady was incidentally diagnosed with 0.5 centimeter solid mass in her gallbladder. So this is a gallbladder with a polyp, which is 0.5 centimeter. Can you tell me the answer of this question? Yeah, I said, Gaurav, that HSV has the highest recurrence among all vagotomies. इन तीनों वेगोटमी में ट्रंकल सेलेक्टिव हाईली सेलेक्टिव में सबसे ज्यादा किसकी रिकरेंस है? HSV। But Gaurav, I think you must be from Bengal or you must be Hindi speaking. Of course, you are Bengali speaking, but you must understand Hindi, I presume. तो अगर वेगोटमी की मैं बात करता हूं तो सबसे ज्यादा रिकरेंस है HSV की अमंग 3 वेगोटमीज। बट अगर मैं कहता हूं ओवरऑल सबसे ज्यादा रिकरेंस किसकी है, तो उसका जवाब है GJ, गैस्ट्रोजेजुनोस्टमी। Have you understood, Gaurav, what I said? So the answer is A. What is the indication of cholecystectomy in gallbladder polyp? Asymptomatic, of course, symptomatic I'll remove. Size more than 10 millimeter, then surgery should be done. So surgery is indicated for any gallbladder polyp which is more than 10 millimeter due to the higher risk of cancer. Okay? If you want to ask any question about polyp or any gallbladder pathology, you are free to ask. Just ask, otherwise I'll go to next question because we have limited time here. So, what about this question? This is an important question. A 45-year female recently admitted with gallstone pancreatitis and was hospitalized for 1 week. She is now 5 weeks out from her admission. So, she is admitted for pancreatitis and she is otherwise fine. अब क्या है कि today her follow appointment sheet, उसको न तो pain है, न vomiting है, न nausea है, nothing. She is fine. And there is collection. WBC is also fine. No fever, nothing. And WBC is also fine. But there's a collection near the pancreas. You see, what is this is kind of a pseudocyst, kind of a. What is the ideal treatment for? The answer is, yeah, so SAF has given one answer. I'm waiting for the answers. Dekho, answer is D. Let me explain a very important concept of acute pancreatitis. Dekho, look at the screen. This blue thing is pancreas. Okay? We are looking at the lateral view. Around the pancreas, there is no capsule, no septa, nothing. It's a retroperitoneal organ. And in pancreatitis, peripancreatic fluid collection is very common. तो पैंक्रियास के आगे यहां पे फ्लूइड कलेक्ट हो गया, जो बहुत कॉमन है, ठीक है, और इसको हम कहते हैं पेरीपैंक्रियाटिक फ्लूइड कलेक्शन. इन acute pancreatitis you get in 30 to 50%. This is managed conservatively. No treatment required if there's just fluid. Listen very carefully. This is the approach for fluid collection in pancreatitis. Conservative. Now there are 3 possibilities. या तो ये absorb हो जाएगा, it gets absorbed, कुछ नहीं करना है, like in this case, कुछ नहीं है, no infection, nothing, absorb हो जाना है, कुछ नहीं करना है. Number 2, it gets infected. तब आप क्या करेंगे? Percutaneous aspiration. So I will go for aspiration of the fluid only if gets infected. Till the time sterile will not do anything. If it gets infected like fever, TLC high, ML is high, you put a needle aspirate. What is the third possibility? Third possibility, it persists. And persists for more than 4 weeks. अब क्या होगा अगर ये फ्लूइड रह गया? नाउ अराउंड दिस फ्लूइड देयर विल बी ए रिएक्शनरी फाइब्रस वॉल. इसको हम कहते हैं स्यूडो पैंक्रियाटिक सिस्ट. So this fluid develops a fibrous wall around it and this is called pseudocyst. What you are looking at as a light blue color space, ये जो space है ना, इसको बोला जाता है lesser sac. Where it is? Behind the stomach. This is stomach. Behind the stomach, anterior to pancreas. So what is the most common site of pseudocyst? Lesser sac. Although it can be found anywhere in the retroperitoneum. और अगर हमने कुछ नहीं किया तो फाइब्रस वॉल बनेगी. इट हैपेंस इन 4 वीक एंड बिकम स्यूडोसिस्ट. एंड स्यूडोसिस्ट आफ्टर 6 वीक if more than 6 centimeter should be surgically treated, otherwise it's prone to get infected, prone to cause internal hemorrhage. इसको हम स्टमक में ड्रेन कर देते हैं ज्यादातर. इसको हम कहते हैं सिस्टोगैस्ट्रोस्टमी. So peripancreatic fluid collection is managed conservatively. We don't do anything. You just wait, the fluid gets absorbed. नहीं absorb होगा, infect हो गया कहीं, तो हम फिर उसको aspirate कर लेते हैं, और persist कर गया तो 4 हफ्ते के बाद वो pseudocyst बन जाता है. Still we don't operate unless it's more than 6 week old and more than 6 centimeter in size. So you see here, it's a asymptomatic fluid collection, not yet 6 week. Patient doesn't have any fever, no infection, nothing. So the answer is D. Have you understood the approach for fluid collection around the pancreas in pancreatitis? Any doubt, any query? If you have any doubt, feel free to ask. I'll not waste time. I'll move on to next question. लेकिन अगर कोई भी डाउट है तो आप फटाफट पूछ लो. See here. ये है पैंक्रियास. दिस ब्लैक थिंग इज पैंक्रियास और ये ब्लू थिंग इज स्टमक और ये ग्रीन थिंग इज फ्लूइड कलेक्शन. और ये बन जाएगा स्यूडोसिस्ट अगर इसकी फाइब्रस वॉल बन गई तो. इट कैन बी कम्युनिकेटिंग विद द डक्ट और नॉन कम्युनिकेटिंग. और उसके बाद हम इसको स्टमक में ड्रेन कर देते हैं, या स्टमक में या जजनम में. वी डू सिस्टोगैस्ट्रोस्टमी और सिस्टोजनोस्मी. अगर तो ये लेसर सैक में है देन वी डू सिस्टोगैस्ट्रोस्मी. इफ इट इज लोअर डाउन समवेयर देन वी डू सिस्टोजनोस्मी. ओके, ट्रांसवर्स कोलन के नीचे सिस्टोजनोस्मी. नेक्स्ट क्वेश्चन. ए पेशेंट आफ्टर लैप्रोस्कोपिक cholecystectomy presented with cystic stump leak, what would be the next management? Can you tell me the answer of this? A, B, C, D. Okay. So I will tell you in 4-5 lines, I will tell you the approach to leak. देखो, the answer is B. You are absolutely correct, all of you. देखो, अगर मान लो ये मैंने बनाया लिवर, this is the right and left hepatic, this is the common hepatic and this is the common bile duct. This is common hepatic duct, this is common bile duct and this is the cystic duct. अगर एक पेशेंट में cystic duct से लीक है, leak is from here, then what we do? ERCP and stenting. Just put a stent and the leak will resolve with time. Just put a stent and leak will, like here. Can you see the cystic duct? I'm sure you can see the clips and you can see the leak here. So these kind of cases are simply managed by ERCP and stenting. What if the leak is from the bile duct? Like this is the cystic duct which is properly closed and there's a cut in the bile duct here. What to do now? If this cut or rent or tear, whether common bile duct, common hepatic, doesn't matter, both are treated same way, less than 50% circumference, just a nick, थोड़ा सा कटा है, तो हम क्या करेंगे? रिपेयर ओवर टी ट्यूब, उसी को सूचर लगा के बंद कर देंगे. लेकिन इफ द बाइल डक्ट इज ट्रांसेक्टेड, ये ऐसे ट्रांसेक्ट हो गई है दो टुकड़ों में, द सर्जन हैज एक्सीडेंटली ट्रांसेक्टेड, और लाइगेट हो गई है, देन व्हाट वी डू? सो फर्स्ट ऑप्शन सिस्टिक स्टम्प लीक, second option bile duct injury but the nick is less than 50%, third the nick is more than 50% or transected if the gap is less, दोनों के बीच में कम गैप है, like this is the upper bile duct and this is the lower, very little gap, or it can have significant gap, tissue loss is there. If the gap is less than 1 centimeter, you can anastomose. CBD to CBD anastomosis. What I call this? Choledocal anastomosis. Yeah, end-to-end anastomosis. Choledocal, अगर gap ज़्यादा है, then what we do? Roux-en-Y esophago, sorry, my fault, hepatico-jejunostomy. I got a little distracted. Roux-en-Y hepatico-jejunostomy. क्या मतलब? जेजुनम को यहां लाके कॉमन हेपेटिक से एनास्टोमोस करते हैं. तो I'll repeat. For CBD injury, if the leak is from the cystic duct, cystic stump leak is from the ear, just ERCP and stenting will suffice. But if CBD has been cut, CBD or common hepatic has been cut less than 50% circumference, repair over T-tube. लेकिन अगर ये ट्रांसेक्ट हो गई है तब क्या करेंगे? गैप कम है तब तो you can do end-to-end anastomosis, और अगर गैप ज्यादा है then do Roux-en-Y. The spelling is Rouxeny, but don't call it Roux-en-Y. It's pronounced Roux-en-Y. Hepatico-jejunostomy. What I mean by hepatico-jejunostomy? ये कॉमन हेपेटिक डक्ट है ऊपर वाली, स्टमक, जेजुनम, कट दिस जेजुनम हियर, टेक दिस अप and anastomose jejunum with the common hepatic and make a Y here. This is called Roux-en-Y hepatico-jejunostomy. Okay, so have you understood? And in case patient have a stricture, बाद में वो stricture लेके आ रहा है, there's another possibility that may later on due to cautery injury patient has developed a stricture of CBD. He comes with cholangitis and jaundice later on. अगर ये stricture possible है, I can pass a guide wire through this. So if it is possible, then I will do balloon dilatation and stenting. Just do balloon dilatation and stenting by endoscopy. And in case it is impossible, tight stricture, then again Roux-en-Y hepatico-jejunostomy. So stricture possible is treated by balloon dilatation and stenting. Impossible treated by balloon dilatation and stenting. Okay. So this is the approach. Have you understood this? Any question you want to ask? So because these are FMGE question, this question has already been asked. ये आपका पूछा जा चुका है पहले. तो चूंकि सिस्टिक स्टंप लीक है तो आप ERC पे स्टेंटिंग करके छोड़ सकते हैं. ओके. दिस इज वेरी इंपॉर्टेंट. ये क्यू सोफा, क्विक सोफा, सीक्वेंशियल ऑर्गन फेलियर असेसमेंट बहुत बार पूछा जा चुका है. This is for infection, pancreatitis everywhere to know the inflammatory state. This includes respiratory rate more than 22, systolic blood pressure less than 100 and Glasgow Coma scale less than 15, 15 से कम. इनमें से any two positive is Q SOFA positive. So ये आपसे frequently दो चीजें पूछी जाती है inflammatory marker. एक पूछा रहता है SIRS, Systemic Inflammatory Response Syndrome. What are the parameters? What is not included? SIRS parameters are temperature more than 38 or less than 36, TLC count more than 12,000 or less than 4,000, pulse rate more than 90, and respiratory rate more than 20 or PaCO2 less than 32. इनमें से कोई भी दो, any two positive, we call it SIRS. Temperature, TLC count, pulse rate and heart rate and respiratory rate. This is what they ask. Shock, or low BP is not a part of SIRS. This is a very, very frequently asked question. They'll give you 4 parameter and they'll say which is not included in SIRS. Blood pressure is not included, only temperature, pulse rate, respiratory rate and PO2 and PLC count is included. क्यों सोफा में ये 3 इंक्लूड करते हैं? A 45-year-old alcoholic patient present with 1 week history of diarrhea, fever, nausea and right up abdominal pain. Ultrasound में there is a abscess और स्टूल में ये मिल रहा है और डायरिया भी है इसको. Can you tell me the diagnosis first, then I'll come to treatment? So, क्या diagnosis है? Tell me the diagnosis. Yeah, oh, that's okay, but what's the diagnosis? You see, first of all, you can see trophozoite 4-nucleated cyst. The diagnosis is amoebic liver abscess. 2 liver abscess, amoebic and pyogenic. Pyogenic will not have diarrhea, will not have trophozoite in the stool. Pyogenic, yeah, you, Sheikh Asif, you are correct. This is amoebic. Hardik, you are also right. So, amoebic liver abscess is generally treated medically. So, what is the treatment for amoebic abscess? The treatment is Metrogel Priyanka, I'll answer your question. Just let me finish this topic. I'll answer your question. I'll tell you the approach. Metrogel 700 milligram TDS into 10 to 14 days. Metronidazole 750-700. If it is not responding, you can give chloroquine and emetin also. Emetin is cardiotoxic, be a little cautious. But any refractory abscess not responding in 5 days, any impending rupture, refractory impending rupture, big cyst more than 10 centimeters, absolute indication more than 5 relative, left lobe abscess, immunocompromised patient, diabetic patient, these are the indication of drainage of the abscess. Okay. So here there's nothing, and abscess is also very small, 75 cc only, one can very well manage conservatively. Now comes the question of Priyanka, that is, what actually, write something, there's a heart shadow covering your, what you have written. So write something so that it goes up and I can see. Okay, let me see. Done in, okay, देखो. Let me explain. देखो क्या होता है कि आपने कोलेसिस्टेक्टमी करा, you have done cholecystectomy. This is the liver, this is the bile duct, and you have placed a drain. यहां पे आपने एक ड्रेन डाल रखा है और ड्रेन में बाइल आ गया, इसका मतलब देयर इज अ लीक. बाइल नहीं आना चाहिए ना, बाइल शुड नॉट कम. अगर ड्रेन नहीं डाला है, देन देयर विल बी कलेक्शन हियर. So the first thing is, when there is a collection, what you do, put a ultrasound guided drain. If you have already placed drain, what you do, observe. तो सबसे पहला काम हमें ये करना है कि drain the collection and observe. This is the step number 1. So in case of leak, drain has already been placed, bile will come out through the drain, drain has not been placed, put ultrasound guided drain and wait. Sometimes the leak disappears क्योंकि थोड़ा सा लिवर सरफेस से ऊज करता है, बाइल वो खत्म हो गया, ठीक हो गया, इट रिजॉल्व, कुछ नहीं करना है, छुट्टी कर दो पेशेंट की, ड्रेन निकालो कर दो. बट अगर ड्रेन चालू, अगर लीक चालू है, फिर क्या करेंगे? ERCP is the best investigation to see the leak. For stricture, it is MRCP. But for leak, it's ERCP. So I will do a ERCP and inject a dye and take X-ray in ERCP, and I'll know from where the leak is, whether it's stricture, whether it's leak. So ERCP is the best investigation to show the leak in injury. Okay. So the first investigation in suspected leak is ultrasound. First, and the best is ERCP. So I guess this answers your question. Can you answer this question? Neuroendocrine tumor of pancreas associated with necrotic erythema, migrans, which tumor? So, what is the answer of question number 11? I just want to confirm, like I started at 7, I'm supposed to finish by 8:30. Is it a fixed time? Can I continue for 10-15 minutes more, or it's a U2 fixed time that we have to finish at 7:30? If it's a fixed time, then probably I'll go a little fast. Otherwise, I might take 10-15 minutes more. Yes. The right answer is glucagonoma. Glucagonoma presents with diabetes mellitus, anemia, stomatitis, and dermatitis. So, this dermatitis is called necrolytic migratory erythema. So, glucagonoma presents with diabetes, anemia, stomatitis and dermatitis, which is called necrolytic migratory erythema, or one can say necrolytic erythema migrans, and deep vein thrombosis. This is the feature. These are the features of glucagonoma. Somatostatinoma presents with diabetes mellitus and gallstones. These are the endocrine tumors of pancreas. And we all know insulinoma presents with hypoglycemia and Whipple striae. Insulinoma presents with hypoglycemia and Whipple striae. Glucagonoma presents with diabetes mellitus, anemia, stomatitis, dermatitis, and DVT. Dermatitis called necrolytic migratory erythema. Somatostatinoma presents with diabetes mellitus and gallstone. That's another question. Which endocrine pancreatic tumor presents with gallstone? Finally, VIPoma. VIPoma presents with WDHA syndrome, which is watery diarrhea, hypokalemia, W for watery diarrhea, H for hypokalemia, and A for acidosis, achlorhydria and acidosis. Watery diarrhea, hypokalemia, achlorhydria and acidosis, WDHA syndrome, also called Werner-Morrison syndrome, WERNER-MORRISON. So these are endocrine tumor of pancreas. You know, gastroma presents with multiple ulcers, Zollinger-Ellison triad. Insulinoma presents with Whipple striae. Patient comes with hypoglycemia, sugar less than 50. You give sugar, he becomes normal. Whipple striae. Glucagonoma, I told you, presents with diabetes mellitus, anemia, stomatitis, dermatitis, and DVT. Dermatitis called necrolytic migratory erythema. Somatostatinoma presents with gallstone. You know, I'll answer your question. Let me finish this. Somatostatinoma presents with gallstone and diabetes, and VIPoma presents with watery diarrhea, hypokalemia, achlorhydria, and acidosis. देखो, अगर आपसे पूछा जाए most common विनोद, listen very careful, it's tricky. अगर मैं कहता हूं कि पैंक्रियास का सबसे कॉमन ट्यूमर क्या है? For pancreas, not your answer your question, in general, total. 98% are exocrine and only 2% are endocrine tumor. एक्सोक्राइन में 90% एडिनोकार्सिनोमा. तो अगर मैं आपसे कहूं कि साहब पैंक्रियास का सबसे कॉमन ट्यूमर क्या है, यू विल से एडिनोकार्सिनोमा. एंडोक्राइन विच इज ओनली 2%, इसमें सबसे कॉमन है पैंक्रियाटिक पॉलीपेप्टिडोमा. So in endocrine, pancreatic polypeptidoma is most common, and this is non-functional. Because it's non-functional, it's silent, it's most of a postmortem study doesn't present. Functional में सबसे common है insulinoma. So when I ask a question, what is the most common endocrine tumor? Generally, this option is not there, which is why this option is not there. In case you have this option, pancreatic polypeptidoma or non-functional, this is the answer. But generally, they don't give this option, so insulinoma is the answer. ठीक? लेकिन अगर मैं कहता हूं सबसे कॉमन मेलिग्नेंट कौन सा है? मोस्ट कॉमन मेलिग्नेंट, मोस्ट कॉमन एंटेरोपैंक्रियाटिक या मोस्ट कॉमन इन मेन सिंड्रोम, मेन 1, तो जवाब है गैस्ट्रिनोमा. So most common malignant endocrine tumor pancreas is gastrinoma, but most common otherwise is insulinoma, functional way, and overall non-functional endocrine tumor. So insulinoma only 10% malignant, gastroma more than 50% malignant. लेकिन VIPoma is more than 70% malignant. Somatocytoma is also 80% malignant. तो इनकी malignancy तो gastroma से भी ज्यादा है. Then why I am saying gastrinoma is most common malignant endocrine tumor? Incidence, gastrinoma has a much higher incidence than VIPoma or somatocytoma. इसीलिए अगर आपसे पूछा जाए कि सबसे कॉमन malignant कौन सा है, तो आप बोलोगे सबसे कॉमन malignant है gastrinoma. ओके, malignant. अदरवाइज सबसे कॉमन एंडोक्राइन ट्यूमर है फंक्शनल में इंसुलिनोमा, एंड ओवरऑल नॉन फंक्शनल ज्यादा कॉमन है पैंक्रियाटिक पॉलीपेप्टोमा. सो दीज आर द क्वेश्चन दे आस्क इन डिफरेंट वेज, मोर कॉमन, मोस्ट कॉमन, ऐसे करके पूछते हैं. सो आई गेस दिस आंसर्स योर क्वेश्चन. Yes, Niranjan. Normally, if I say what is the most common endocrine tumor pancreas, then saying gastrinoma is not wrong. Gastrinoma having the malignant potential of 80%, 60%, 56%, most common endocrine tumor is gastrinoma, which is malignant. So, can you answer this question? A patient presented with malabsorption and found to have architectural changes in villi and crypt in the intestine. Yes, very good. ये so you see, now, okay, so this condition is celiac disease due to gluten. How you get the idea? Gluten is a protein found in wheat, barley, rye and oat. आपको दो चीजें मिलेंगी, एक तो वेलाई का डिस्ट्रक्शन मिलेगा, दूसरा टीटीजी या एंटी एंडोमाइसियल एंटीबॉडी पॉजिटिव, टिश्यू ट्रांसग्लूटामिनेज और एंटी एंडोमाइसियल पॉजिटिव. और तीसरा क्वेश्चन वो पूछते हैं HLA-DQ2 पॉजिटिव, rarely DQ8 positive. So celiac disease, how you get the idea? Gluten sensitive enteropathy, villi will be short, small, atrophic, HLA-DQ2 or DQ8 positive, or anti-TTG, anti-tissue transglutaminase or anti-endomysial antibody positive. ये हमें बताता है ये celiac disease है, which is a gluten sensitive enteropathy. Yeah, so you are right, it's celiac disease. Internal opening of renal fistula is located at. इसका क्या जवाब होगा भाई? Yes. Okay, so देखो ये है anal canal in rectum. This is the levator ani, LANLA. This is puborectalis, PNP. The right answer is dentate line here. Okay, let me explain. तो दो मसल मैंने बनाई, एक है लेवेटर एनाई, एक है पिब्रेक्टालिस, और एनल कनाल की जो एक्सटेंट है ना, दिस इज फ्रॉम एनल वर्ज टू एनोरेक्टल रिंग। ये जो लाइन है ये कहलाती है एनोरेक्टल रिंग। सो एनल कनाल एक्सटेंड्स फ्रॉम एनल वर्ज टू एनोरेक्टल रिंग, और यहां पे ना बीच में देयर इज ए लाइन ऑफ एनल वाल्व, दिस इज कॉल्ड डेंटेट लाइन। ये एनल वाल्व होता है, उसके पीछे एनल क्रिप्ट होता है। सो दिस इज अ लाइन विच इज फॉर्म्ड बाय एनल वाल्व हैविंग एनल क्रिप्ट, और ये कहलाती है डेंटेट लाइन। ओके, सो दिस इज द वेरी बेसिक स्ट्रक्चर, एनल कनाल एक्सटेंडिंग फ्रॉम एनल वर्ज टू एनोरेक्टल रिंग हैविंग डेंटेट लाइन इन द सेंटर। ये जो म्यूकोजा है, ये वाली ऊपर वाली, दिस इज कॉलमनर, और ये जो म्यूकोजा है दिस इज स्क्वामस। सो एनल कनाल हैज टू टाइप्स ऑफ म्यूकोजा, कॉलमनर एंड स्क्वामस। कॉलमनर इज अबव डेंटेट लाइन, स्क्वामस इज बिलो डेंटेट लाइन. Columnar is pain insensitive, squamous is pain sensitive. And hemorrhoids are divided into internal and external by डेंटेट लाइन ओनली. ठीक है, इंटरनल जो है वो डेंटेट लाइन. हेमोरॉइड्स, फिस्टुला की बात नहीं है, फिस्टुला की नहीं, हेमोरॉइड की बात करो. पाइल्स, इंटरनल एक्सटर्नल. नाउ दिस इज इंटरनल स्फिंक्टर हियर एंड दिस इज एक्सटर्नल स्फिंक्टर. दो स्फिंक्टर होते हैं, इंटरनल इनवॉलेंट्री, एक्सटर्नल वॉलेंट्री. और यहां पे दिस इज द एनल ग्लैंड जो बाहर ऐसे रप्चर कर जाती है, एब्सिस बनकर ये बन जाता है फिस्टुला. So always fistula की internal opening कहां होती है? At the dentate line, at the anal crypt, behind the anal valve. Always. बाद में और भी बन जाएंगे. तो fistula in ano is a abscess of perianal area. ये abscess है जो anal gland से होकर वहां rupture हो जाती है. So internal opening is always at the dentate line. Later on it can have more opening. अगर ये opening anal एनोरेक्टल रिंग के ऊपर जा रही है, देन यू कॉल इट हाई टाइप ऑफ फिस्टुला एंड दिस इज लो टाइप. सो हाउ यू डिवाइड लो एंड हाई टाइप फिस्टुला एंड एनो? बाय एनोरेक्टल रिंग. हाउ यू डिवाइड हेमोरॉइड इंटरनल एक्सटर्नल? बाय डेंटेट लाइन. अंडरस्टूड दिस? सो दिस इज क्रिप्ट एट द डेंटेट लाइन बिहाइंड द एनल वाल्व. हाँ, अगर मैं कहता लो और हाई टाइप कैसे डिवाइड करते हो, तो आप बोलोगे एनोरेक्टल रिंग. तो हम एनोरेक्टल जंक्शन इससे डिवाइड करते हैं, लो एंड हाई टाइप. So have you understood this question? Any doubt here? So fistula internal opening will be at the anal verge, at the anal crypt behind the anal valve, but later on it can have other openings as well. And in case the tract goes above the anorectal ring, we call it high type fistula. Below anorectal ring, we call it low type fistula. So any doubt here? So this is anal canal, this is the dentate line, this is anal verge, this is the anorectal ring. I have written AR. और ये है इंटरनल स्फिंक्टर I और ये है एक्सटर्नल E. एक्सटर्नल वॉलेंट्री होता है. यहां पे एनल ग्लैंड होती है जो यूं रप्चर कर जाती है इस तरह से. ये फिर हमारी डिफरेंट टाइप ऑफ फिस्टुलास बनते हैं, इंटरस्फिंक्ट्रिक, ट्रांसफिंक्ट्रिक, सुप्रास्फिंक्ट्रिक, एक्स्ट्रास्फिंक्ट्रिक. इस लाइन के ऊपर हाई टाइप बन जाता है. ओके, देयर आर डिफरेंट टाइप ऑफ फिस्टुला व्हिच आई विल नॉट डिस्कस, वी डोंट हैव दैट मच टाइम. So any question here? Have you understood the anal? Okay. A patient presented with rectal prolapse. On clinical examination, there was a growth at the anal verge. So squamous cell cancer is treated by what? Can you tell me? Again, important question. So as I told you, ये है लेवेटर एनाई, ये है डेंटेट लाइन, इसके ऊपर एडिनोकार्सिनोमा, इसके नीचे स्क्वामस सेल कैंसर. एडिनोकार्सिनोमा इज ट्रीटेड बाय APR, एब्डोमिनोपेरिनियल रिसेक्शन. स्क्वामस सेल कैंसर इज ट्रीटेड बाय नाइग्रो रेजिम. व्हाट इज नाइग्रो रेजिम? कीमो रेडियो. So squamous cell cancer anal canal is treated by chemo radiation, which is called nigroregime. So all of you already know this. I see all of you have answered C, which is the right answer. But if I change my question and rather than squamous cell, if I say adenocarcinoma, if I remove squamous cell and say adenocarcinoma of the anal canal is treated by what? Then the answer will be APR, which is very rare. Don't worry. Squamous cell anal canal is much more common than adenocarcinoma. So normally they ask only squamous cell. Nigro regime, chemoratio for squamous cell cancer anal canal. Now a question from hernia. Hernia is an important topic for your exam. So, intestinal loop passes along the cremasteric cord and reaches till base of scrotum. Which type of hernia is this? So, what is the answer? APR full form is abdominoperineal resection. देखो मैं समझा देता हूं. किसने पूछा है? सना देखो मैं समझाता हूं. मान लो ये रेक्टम है और ये एनल. दिस अनदर एमसीक्यू, वेरी इंपॉर्टेंट. दिस इज एनल कनाल हियर, फ्रॉम हियर टू हियर. एनी कैंसर within 5 centimeter from anal verge, any cancer here, rectal cancer, upper anal canal, is treated by APR, which stands for abdominoperineal resection. So, abdominoperineal resection is not only for cancer adenocarcinoma of the anal canal, it's also a treatment for rectal cancer provided it is within 5 centimeter. और अगर ये कैंसर 5 सेंटीमीटर के एनल वर्ज इसके ऊपर है, ये जो दूरी है मोर देन 5 सेंटीमीटर, देन दिस इज ट्रीटेड बाय AR, which stands for anterior resection. So cancer within 5 centimeter of anal verge is treated by APR और इसका फुल फॉर्म है abdominoperineal resection. एब्डोमिनोपेरिनियल रिसेक्शन, पेरिनियल. और अगर इसके ऊपर है 5 सेंटीमीटर के ऊपर है तो उसके लिए हम क्या करते हैं? एंटीरियर रिसेक्शन. ओके, आई होप यू अंडरस्टूड दिस पार्ट. सो व्हाट इज द आंसर ऑफ दिस क्वेश्चन? यू हैव रिटन सी. यस, अगेन, सो दिस इज क्वाइट गुड. नो, नॉट फ्रॉम डेंटेट लाइन. निरंजना, दिस इज वेरी इंपॉर्टेंट. डेंटेट लाइन से दूरी नहीं है. दिस दूरी, दिस डिस्टेंस इज फ्रॉम एनल वर्ज. लेट मी एक्सप्लेन. दिस इज वेरी इंपॉर्टेंट. Don't commit this mistake in exam. The distance is from the anal verge 5 centimeter. If I say dentate line, then the same distance becomes 3 centimeter. Dentate line is 2 centimeter above the anal verge. So if I am saying dentate line, Niranjan Kumar, then it is 3, more than 3 AR, less than 3 APR. Understood this part? Okay. तो यहां भी आपका जवाब बिल्कुल सही है, आप सारे लोगों का. शेख आसिफ, सैफ, शीरू, निरंजन, एटलीस्ट आई एम ट्राइंग, नॉक्स, सभी का सही है. सी इज द राइट आंसर. देखो क्या छोटे छोटे पॉइंट पूछे जाते हैं हर्निया में. This is ASIS, this is inguinal ligament, this is pubic tubercle, pubic symphysis, this is the rectus muscle, and this is the internal ring and external ring. Deep ring and superficial ring, this is the inguinal canal, and this is the inferior epigastric artery. Okay, I hope you know the anatomy. We don't have time to discuss anatomy. Deep ring is a defect in fascia transversalis. Superficial ring is a defect in external oblique aponeurosis. Now, indirect hernia comes out through the internal ring. ये यहां से बाहर आता है. So, the sac is lateral to inferior epigastric artery. बाहर तो इसी छेद से आ रहा है, external opening से, but internal defect is from the internal ring, deep ring. And direct hernia comes out from Hasselback's triangle. This also comes out from the external ring, but अंदर से इस एरिया से आता है. So direct hernia is coming out from a triangle here. Indirect hernia comes out from the deep ring. Indirect hernia is indirect. And what are the triangle? What are the boundaries? The boundaries are, this is the triangle. See this for direct hernia. What are the boundaries? Boundaries are inferior epigastric artery, rectus muscle and inguinal ligament. Okay? So these are the boundaries. So first of all, we have to know the basic difference. What's indirect and direct hernia? Both are inguinal hernia. Indirect hernia comes out from the deep ring, internal ring, and comes out finally through the external ring. And direct hernia comes out through the Hasselbalch triangle. Direct hernia is medial to artery, and indirect hernia is lateral to the artery. You can see this is lateral, this is medial. Indirect hernia is common in young age, direct in old age, and direct can be bilateral. Direct hernia goes up to the base of the scrotum. So it's going to base of scrotum, it's indirect hernia, it's protruding anteriorly, it's direct hernia. As you can see, the question says going up to the base of the scrotum. Treatment and obstruction is more in the indirect hernia. Obstruction, more in the indirect hernia. And the treatment for both is hernioplasty. For congenital hernia, herniotomy. For adults, hernioplasty. Femoral hernia comes out from here. So, another important point they ask, femoral comes out from here. So, femoral is inferior and lateral to pubic tubercle. So, if in question the swelling is inferior and lateral to pubic tubercle, it's a femoral hernia, and superior and lateral to pubic tubercle, it's a inguinal hernia. So, femoral is inferior and lateral to pubic tubercle, inguinal is above. And what are the boundaries of femoral ring? So, this is the ASIS and pubic tubercle. This, let's say this is a pubic ramus, pectineal ligament. This is pectineal ligament. I'm using green color. And this is the femoral vein here. And this light green color is the lacunar ligament. We don't have time to discuss complete anatomy, but at least I'll tell you the boundaries of femoral ring. Femoral ring is this place, this is space. This is femoral ring, this, here, this. Bounded by anteriorly inguinal ligament, medially lacunar ligament, posteriorly pectineal ligament, laterally femoral vein. So, anterior inguinal ligament, medially lacunar ligament, posteriorly pectineal ligament, laterally femoral vein. This is called femoral ring, and through this hernia we have femoral hernia, which will come out here. So this is inferior and lateral to pubic tubercle. So because here it is going up to the base of scrotum, it's a indirect hernia. So have you understood a little bit? Of course, hernia I cannot finish in 5 minutes. It's a 2 hours topic, but I hope you have understood the basic question concept. So you want to ask anything about hernia or any question, you can ask. I'll just wait for 1 minute. So any question about this particular, any doubt about on this particular question? Okay. So this is basically the diagram. Surgery for surgery for all hernias are same, inguinal. Direct and indirect, they are treated by same technique. We have hernia may, I'll just write down few names of surgery. As you know, we don't have time to discuss the whole hernia, but I'll tell you the name. Number 1, for congenital hernia and hydrocele. Congenital, not to be confused with adult hydrocele. Both are due to patent processes vaginalis. Both are treated by herniotomy. This surgery is only and only done for congenital hernia and hydrocele. Congenital, acquired is total. Herniotomy, and it's only for children. Herniotomy is not done in adults, only for children. Congenital hernia. Why congenital hernia and hydrocele? The base of a scrotum is, it's an indirect inguinal hernia. Indirect inguinal hernia. Direct inguinal hernia protrudes anteriorly, not going down. Number 2, for adults hernia, we have 2 surgeries, herniorrhaphy, HERNIORRHAPY. I am not sure whether you have access to Back to Basic of DUMS. If you have, I have taken hernia lecture in Back to Basic. You can see the recording. herniorrhaphy, and third operation is hernioplasty. Hernioplasty. So what's the difference? Herniorrhaphy, HERNIORRHAPHY, and hernioplasty, these are for adult hernia. What's the difference? In herniorrhaphy, local tissue is used for repair. In herniorrhaphy, you use some extrinsic product, some processes, some mesh. Like in India, we use Prolene mesh, but Gore-Tex mesh, PTFE, other thing can be used. So the difference in hernioplasty and herniorrhaphy is basically what? I will use this. So the difference in herniorrhaphy and hernioplasty is what? In herniorrhaphy, we use local tissue. In hernioplasty, we use ready-made product. Herniorrhaphy examples are Bessini, Bessini. Bessini is father of modern hernia surgery. Shouldice, Shouldic. De Sarda, Desarda. Darning, but darning is not really a herniorrhaphy, but still I can write darning. And for hernioplasty, we use mesh, most commonly Leichtenstein, Leichtenstein repair, most commonly. Laparoscopic repair, tip and tap, these are also hernioplasty. These are laparoscopic repair. For femoral hernia, we have low approach, high approach, and inguinal approach, old approaches. Now we are doing laparoscopically, but if I am doing open surgery, then low is called Lockwood, Lockwood, Lockwood. High is called McEvedy, Mcevedy, and inguinal is called Lothesian. Lockwood, McEvedy, and Lothesian. These are surgeries for femoral hernia. We have one more, McWay, MCWAY, McWay. What we do in each one of them, I don't think we have time to discuss all this. It's not a lecture on hernia, just to tell you some concept. So hernioctomy is only done for children, congenital hernia and congenital hydrocele. While herniorrhaphy, where we only use local tissue to repair, can be Bessini's, can be Shouldice, can be De Sarda, can be Darning. There's some more type as well. Hernioplasty, only one name, Leichtenstein, the most commonly done surgery. Or laparoscopic tap and tap repair, all also examples of hernioplasty. So this is just to answer your question. Okay, have you understood the names? So what other question? How to manage complicated hernia? Well, complicated hernia, just obstruction and strangulated hernia, so it's same. Like you do herniorrhaphy, hernioplasty, and if there's a gangrene, you resect. नहीं भैया, ऐसा कुछ नहीं करते सैफ भैया, गौरव सर ने ऐसा नहीं बोला होगा. मच्छरदानी यूज नहीं करते हैं, हम मेश यूज करते हैं. इंडिया में मेश की कीमत बहुत सस्ती हो गई है. When I was doing my residency ना, उस जमाने में मेश आता था 3-4 हजार का, तब 3-4 हजार बहुत होते 30 साल पहले. अब मेश आता है 300 रुपए का, 200-300 रुपए का. Nobody will use मच्छरदानी when you can buy something for 200-300 rupees. Although there was a doctor who proved that machhardani, he was from Maharashtra, a surgeon, who proved that machhardani mesh is as useful and as sterile as a Prolene mesh. He did a study, he proved it. Unfortunately, he died in corona epidemic. I read in a news, he died. But वो कोई ऐसा standard procedure नहीं है, हम लोग Prolene mesh use करते हैं. ये गौरव सर ने बोला होगा, तो ऐसे बताने के लिए बोला होगा, आप इसको सच मत मानिए. बेस ऑफ स्क्रॉटम जो है इनडायरेक्ट जाता है, इनडायरेक्ट कैन रीच अप टू बेस ऑफ स्क्रॉटम. ओके, सो व्हाट इज आंसर हियर? ओ, अनफॉर्चुनेटली आंसर इज ऑलरेडी रिटन हियर, ये डिलीट नहीं हुआ. देखो, मैं आपको ना कुछ छोटे छोटे पॉइंट समझाना चाहता हूं. देखो, कभी कभी क्या होता है ना कि वी हैव डुप्लेक्स सिस्टम, टू यूरेटर्स ऑन वन साइड. व्हेन वी हैव टू यूरेटर कॉल्ड डुप्लेक्स सिस्टम और डबल मोइटी, तो एक रूल फॉलो होता है, उसे कहते हैं विगर्ट मेयर लॉ. विगर्ट मेयर लॉ, Vigert, WIEGERT, Mayer law. This is for Vigert Mayer law is for two ureters on one side. इसका ये कहना है कि this is the bladder, this is one ureter, don't draw, just watch. This is another, I'm using two color, this is another ureter. And there are two kidney which are fused. Double moiety, two system. इस लॉ का यह कहना है कि व्हाट आई हैव ड्रॉन हियर ऐसा कभी नहीं होता. ऑलवेज बोथ यूरेटर विल क्रॉस. सो विगर्ट मेयर लॉ ये कहता है, यूज टू कलर, वन ब्लू एंड वन रेड, सो दैट वी अंडरस्टैंड. इट सेज व्हेन देयर आर टू यूरेटर दे विल क्रॉस. द अपर यूरेटर विल ओपन inferomedially and lower will open superolaterally because they will cross. ठीक, ये है विगर्ट मेयर लॉ. अपर यूरेटर, अपर किडनी यूजली कॉन्स्टिट्यूट 1/3, लोअर 2/3. और ये जो लोअर मोइटी है, ये जो यहां खोल रही है, दिस हैज प्रॉब्लम ऑफ VUR, वेसाइको यूरेट्रिक रिफ्लक्स, एंड दिस हैज ए प्रॉब्लम ऑफ यूरेट्रोसील. जब यूरेटा ब्लैडर में आके ऐसे फूल जाता है तो उसको यूरेट्रोसील कहते हैं. तो ये तो एक छोटा सा पॉइंट है विच आई वांट यू टू रिमेंबर, दैट व्हेनेवर टू यूरेटर्स आर देयर, दे विल क्रॉस, दे विल नॉट गो स्ट्रेट, विच इज व्हाई आई रोट, मैंने कहा पुराना डायग्राम मत बनाना, ये बना सकते हो, पुराना वाला मत बनाना, जब मैं दोनों को अलग अलग बना रहा था, जस्ट टू एक्सप्लेन. तो दे विल ऑलवेज क्रॉस. अब ये जो एन अपर ओपनिंग विच इज फॉर लोअर पोल विल हैव रिफ्लक्स एंड लोअर ओपनिंग विल हैव यूरेट्रोसील. अब आता है एक्टोपिक यूरेटर. ये एक्टोपिक भी हो जाता है. दिस इज अ ब्लैडर, दिस इज द यूरिथ्रा इन मेल, दिस इज द प्रोस्टेट एंड दिस इज द एक्सटर्नल स्फिंक्टर. ये जो ग्रीन है ये एक्सटर्नल स्फिंक्टर है. ये यूरेटर यहां खोल रहा है इन मेल. एक्टोपिक यूरेटर इन मेल कैन ओपन हियर इन द प्रोस्टेटिक यूरिथ्रा. It can open in vast difference. It can open anywhere, but never below the external sphincter. ये हमेशा इसके ऊपर ही खोलेगा, ब्लैडर नेक पे, प्रोस्टेट पे. और चूंकि it will open above the external sphincter, incontinence you never get in male. While in female, one bladder ureter opening here, and the urethra is only 4 centimeter in female. In male, it's 20 centimeter. It opens in the urethra, it opens in the vagina, it can open anywhere. So it causes incontinence. A ectopic ureter can never cause incontinence in male because no matter where it opens, it will always open above the external sphincter, the green line. While in female, it opens in the vagina, in the urethra, it can cause incontinence. So when a girl is having two ureter, one ureter is normal, one is ectopic, this will fill the bladder, she has the normal voiding. At the same time, this will cause incontinence. ये सवाल आपका बड़ा इंपॉर्टेंट सवाल है जो आ चुका है, ये पीजी एंट्रेंस में भी आ चुका है. Why it is not ectopia vesicae? Because she is having normal voiding. How normal voiding can have ectopia vesicae? Ectopia vesicae, bladder is open. So she will have continuous dribbling of urine. कॉन्टिन्यूस ड्रिबलिंग तो है ही, बट साथ में नॉर्मल वॉइडिंग भी हो रही है. वाई? वन यूरेटर ओपन्स इन द नॉर्मल पोजिशन, सेकेंड यूरेटर ओपन्स इन urethra or in the vagina. So this is causing the incontinence, this is causing the normal voiding. Have you understood this question? In male, I told you ectopic ureter can never cause incontinence because no matter where it opens, it will always be above the external sphincter. So I'll just repeat what I said. मैंने आपसे कहा कि अगर ये तो डबल यूरेटर और एक्टोपिक यूरेटर में कंफ्यूज मत करना. मैंने कहा कि अगर डबल यूरेटर है, दे विल ऑलवेज क्रॉस. ये तो पहला रूल है विगर्ट मेयर लॉ. फिर मैंने कहा कि दिस यूरेटर कैन बी एक्टोपिक, दिस वन, और हो सकता है डबल यूरोटेक्टोपिक हो सकता है सिंगल यूरोटेक्टोपिक हो, मतलब उस साइड में दो यूरोटा होना जरूरी नहीं, सिंगल यूरोटा भी एक्टोपिक हो सकता है, लेकिन अदर साइड का तो नॉर्मल है ना. So when one ureter is normal filling the bladder, the girl will have normal voiding, normal micturition. But other ureter is opening the urethra, so she will have continence dribbling. So normal voiding and incontinence at the same time suggest two ureter, one opening in the bladder, one opening in the urethra. So she is having incontinence. But in male, she will not. The person will not have incontinence if there is a ectopic ureter. This is a little complex part of embryology, but this is a commonly asked question. अगर ये समझ गए हो तो अच्छी बात है, नहीं समझे हो तो कोई बात नहीं, दो लाइनें याद कर लो. एक तो याद रखो कि when there are two ureter on one side, they cross Wiegert-Mayer law. दूसरा याद रखो कि if a girl, ये सवाल बार बार आता है, कई बार आ चुका है, if a girl is having normal voiding at the same time she is having incontinence, this is due to ectopic ureter. The right answer is D. So these two line you remember, okay? देखो, एक यूरेटा ब्लैडर में खोल रहा है, एक यहां खोल रहा है, इससे नॉर्मल वॉइडिंग होगी, इससे इनकॉन्टिनेंस होगा. लेकिन मेल में इट ऑलवेज ओपन अवर द एक्सटर्नल स्फिंक्टर, तो कभी भी इनकॉन्टिनेंस नहीं होता है. और ये विगर्ट-मेयर लॉ है जो क्या बता रहा है, ऑलवेज द यूरेटर विल क्रॉस. और मैंने बताया ये वाला जो यूरेटर है ब्लैक कलर वाला, इसमें यूरेट्रोसील होगा, और ये वाला जो यूरेटर है ब्लू कलर वाला, इसमें जो ऊपर ओपन होगा, इसमें VUR होगा. दिस इज ए डबल यूरेटर. ठीक है, समझ में आ गई ये बात? कैन यू टेल मी द आंसर ऑफ दिस क्वेश्चन? A patient presented in OPD with hematuria. He has been suffering from recurrent UTIs. You just have to see the CT scan. They want you to make a diagnosis. ये आपका आ चुका है पहले, और ये है एक स्ट्रक्चर जो यूं जा रहा है. I will give you a hint. मैंने बना दिया है, क्या स्ट्रक्चर आपको देखना है. Yes. Again, सैफ, नॉक्स, निरंजन, गौरव, विनोद, शोएब, बिया बिजू, प्रिया, शीरू. नो, शीरू का गलत हो गया जवाब, कोई बात नहीं, बाकी सबका सही है. So, see, I'm happy that almost 99% answers are correct, and this is a horseshoe kidney. हमें horseshoe kidney के क्या points पता होने चाहिए? What all points we need to know? Just 5-6 line. First, so this is a horseshoe kidney. This is which artery? Inferior mesenteric artery. The ascent will be T3rd. So isthmus is found at the L4 level. Below inferior mesenteric artery, and this is the most common renal fusion anomaly. तो क्या क्या पॉइंट आपको याद रखने हैं? नंबर 1, मोस्ट कॉमन renal fusion anomaly. नंबर 2, इंसिडेंस छोड़ दो, इसकी जरूरत नहीं है. नंबर 3, ये भी छोड़ दो. नंबर 4, किडनी ऑलवेज नॉर्मल एट L4 बिलो द inferior mesenteric artery. IVP में क्या मिलता है? फ्लावर वास अपीयरेंस. व्हाट इज फ्लावर वास अपीयरेंस? फ्लावर वास अपीयरेंस इज, ये राइट किडनी है, ये लेफ्ट किडनी है. नॉर्मली द IVP विल शो माइनर कैलिसेस लाइक दिस. ये नॉर्मल किडनी होगा, ठीक है. बट इन हॉर्सशू किडनी द लोअर पोल इज फ्यूज्ड लाइक दिस. लोअर पोल जो है ये फ्यूज्ड है. नाउ द माइनर कैलिक्स विल बी लाइक दिस, लाइक दिस, लाइक दिस. बट अब मैं ब्लू कलर यूज कर रहा हूं. जैसे एडिशनल माइनर कैलिक्स गोइंग लाइक दिस, ये एडिशनल है. सो इंफीरियर मोस्ट माइनर कैलिक्स इज मीडियली डायरेक्टेड. इसी को कहते हैं, अगर दोनों साइड में ऐसा हो गया ना तो हैंडशेक या फ्लावर वास. सो सी, दिस इज ए इंफीरियर मोस्ट माइनर कैलिक्स विच इज मीडियली डायरेक्टेड. ये बड़ा क्लासिकल IVP फीचर होता है. बट IVP वी डोंट ऑर्डर एनी मोर, वी ऑर्डर CT स्कैन. नाउ CT हैज बिकम द इन्वेस्टिगेशन चॉइस. IVP इज द ओल्ड इन्वेस्टिगेशन, बट स्टिल फ्लावर वास साइन इन IVP वन शुड नो. सो एंड देयर इज नो ट्रीटमेंट. डोंट कट दिस सिस्टमस टू मेक द हॉर्सशू नॉर्मल. हमने कहा चलो इसको काट देते हैं, नहीं, कोई फायदा नहीं होगा. खाली कॉम्प्लिकेशन ट्रीट कर, ओनली ट्रीट द कॉम्प्लिकेशंस लाइक स्टोन, PUJ obstruction, whatever is there, you treat it. Okay? So these are the points you need to know about horseshoe kidney. Any doubt, any question? and the shape is like a horseshoe, which is why you call it horseshoe kidney. ठीक है? Understood? Now the next question. So I guess there's no question. Identify the investigation. क्या है ये? पहला तो आप बताओ सीटी है या एमआरआई है? This is, yeah, Niranjan, this question, what you have asked, is a question, I'm surprised that you are still being taught this. This is a question when I was a student, I was taught this, and we used to get this kind of question. That what is the absolute indication of the resection of isthmus in horseshoe kidney? ये हमारे जमाने का क्वेश्चन है और हमें ये पढ़ाया जाता था कि this is the aorta, this is aneurysm, and because horseshoe is just anterior, so you have to cut the isthmus to repair the aorta. That was the absolute indication. That was. Now we do have a retroperitoneal approach. So one can repair aneurysm without cutting the isthmus even in horseshoe. So although it's an indication, but not an absolute indication. But I am surprised that still this is being taught. This is what I was taught when I was a student, that isthmectomy, the absolute indication is aneurysm of aorta. So it is an indication but not absolute anymore. Another thing that they do ask in horseshoe kidney, this is the kidney, this is the upper calyx, middle calyx and lower calyx. There's a stone and we do PCNL, percutaneous nephrolithotomy. So normally we do PCNL from the inferior calyx. But in horseshoe kidney, we do PCNL from the superior calyx. That's another question sometimes asked. But I doubt कि FMGE में आपसे पूछा जाएगा. या NEET PG वगैरह में कभी-कभी पूछ लेते हैं कि आप stone कहाँ से निकालेंगे PCNL में? From the upper calyx, if it's a horseshoe kidney. Okay? So this I hope answers your question, Niranjan. So this is a MRI. Why MRI? The bones are black. In CT scan, the bone will be white. And what is answer? This is polycystic kidney disease. क्या पॉइंट्स हमें पता होने चाहिए पॉलीसिस्टिक किडनी डिजीज के बारे में? अगेन 4-5. Number 1, autosomal dominant polycystic kidney disease, chromosome 16 and 4, PKD1, PKD2 gene. Liver, yeah, bone black. You are right, Mohit. The liver is the second most common organ having cyst. Kidney most common, followed by liver. You can get cyst rarely in spleen, pancreas, lung and ovary, but not in testis, not in brain. Brain में क्या मिलता है? Subarachnoid aneurysm, berry aneurysm. Heart में mitral valve prolapse syndrome and colon में diverticulosis. This kidney will become non-functional with time. So eventually patient will have hypertension, hematuria, pain and finally CRF by the age of 57, between 50 and 70 years, requiring transplant. Transplant is the only definitive treatment. CT is the investigation of choice, but IVP shows spider leg deformity. We don't order IVP now. So these are the point we need to know. PKD1 and PKD2 gene. Forget the name, only forget all this. ये FMGE में कुछ नहीं पूछेंगे. Only remember the chromosome 16 and 4. ये भी इसकी भी जरूरत नहीं है. ये सब ड्रग वर्क की कोई जरूरत नहीं, सब छोड़ दो, ये आपके लिए नहीं है. So you do, this is CT scanner, you can see the bone white. So you do get question like this. So this is the image they give और फिर वो पूछते हैं इस फोटो पे कि which chromosome are involved. No, Rovsing is obsolete भाई. कौन ये सब पढ़ा रहा है आप लोगों को Rovsing ऑपरेशन आज की तारीख में? Rovsing is obsolete. We don't do Rovsing. ये तो बहुत पुरानी टीचिंग है. Rovsing operation is only historical. Roofing is de-roofing of cyst. De-roofing, not done. Roofing can relieve pain if pain is there. That's it. उसके अलावा roofing का कोई फायदा नहीं है. It will not make the polycystic kidney normal. It will not correct the kidney. You have to do transplant eventually. So if you know roofing operation is done, that's good. ये नाम पता होना चाहिए. लेकिन याद रखो कि करते नहीं है. खाली ये historical है. It's not done anymore. The treatment finally is transplant when the kidney fails. Before that, medical treatment. So this is a polycystic kidney with polycystic liver as well. So they show these kind of images and ask which chromosome is involved. Chromosome 16 and 4. And autosomal recessive, chromosome 6. ARPK, autosomal dominant, 16 and 4. Most common type of renal stone. So any question about polycystic kidney? I guess you have understood this. Quickly, फटाफट answer करो. We are running short of time. Most common renal stone. Yes, Niranjan, good. Dr. T, Knox, Mohit, Saf. Good, good. Okay. So again, it's good to see that almost all answers are correct. Answer is calcium oxalate. मैं आपको ना renal stone के 8-10 लाइनें बता देता हूं for which are important, which you need to know, which are MCQ. देखो, most common stone in kidney is calcium oxalate, and if you want to know full, calcium oxalate dihydrate. There is something called calcium oxalate monohydrate, which is very rare. Calcium oxalate monohydrate जो बहुत रेयर होता है, बट इसकी इंपॉर्टेंस ये है कि ये हार्ड होता है. इट्स नॉट ब्रोकन अप बाय ESWL. सो लिथोट्रिप्सिस से ब्रेक नहीं होता है, बट मोनोहाइड्रेट इज रेयर. इट्स नॉट ए कॉमन टाइप. Most common type is calcium oxalate dihydrate. What are the other common stone? Other stone is uric acid. What is the feature? Radiolucent, not seen on X-ray, and cystine. And both uric acid and cystine, they form in acidic urine. While phosphate forms in alkaline urine, and this is called triple phosphate या magnesium ammonium phosphate. So triple phosphate or magnesium ammonium phosphate forms in alkaline urine, and cystine and uric acid forms in acidic urine, while calcium oxalate can form at any pH. ये अल्कलाइन एसिडिक किसी पे भी बन सकता है. ठीक, अब आता है नेक्स्ट पार्ट. फॉस्फेट होगा कब? अल्कलाइन. अल्कलाइन यूरिन कब होगा? इन्फेक्शन. सो इन्फेक्शंस बाय बैक्टीरिया, especially Proteus, which converts urea into ammonia by protease or urease, and ammonia will make alkaline. E. coli is the most common pathogen bacteria for UTI. is not urea splitting. E. coli सबसे कॉमन बैक्टीरिया, लेकिन यूरिया स्प्लिट नहीं करता, ये फॉस्फेट स्टोन नहीं बनाता. फॉस्फेट स्टोन इज फॉर्म्ड बाय प्रोटियस, क्लेब्सियला, स्यूडोमोनास, मेनी बैक्टीरिया कैन कॉज दे आर यूरिया स्प्लिटिंग, नॉट E. coli. फॉस्फेट इज स्मूथ और वो अपनी जगह पड़ा पड़ा बड़ा होता जाता है. सो फाइनली इट गेट्स ए शेप लाइक दिस, like Mannei-Calis and pelvis, and this is called staghorn calculus. Staghorn calculus. Stag का मतलब बारहसिंगा, मेल डियर, उसके सिंग की तरह. Staghorn, horn of a stag. So what is staghorn calculus? This is a phosphate stone seen in infected urine. Now, this is the kidney. These are the minor calyces. when the stone is in the minor calyx, which is very common in Delhi, in Gujarat, in Rajasthan, Haryana, this is a stone belt. So patient comes with a small stone in calyx, we keep under observation. हम इसको नहीं कहते हैं कि ऑपरेट कराओ अगर पेशेंट एसिम्प्टोमेटिक है. अगर पेन है, KU मतलब कीप अंडर ऑब्जर्वेशन. अगर पेन है, then we can advise ESWL, extra corporeal shockwave lithotripsy. For lower calyx, ESWL is not as good, so we can go for RIRS. Although it's not contraindicated. तो कैलिशियल RIRS से भी समझाता हूं. सो कैलिशियल स्टोन के लिए आप लिथोट्रिप्सी यूज करेंगे तब जब सिम्टोमेटिक है. लोअर के लिए यू हैव टू टेल द पेशेंट भाई क्लियरेंस थोड़ी यहां खराब है तो RIRS बेटर रहेगा, बट लिथोट्रिप्सी भी करा सकते हैं. नाउ व्हाट अबाउट व्हेन द स्टोन इज इन पेल्विस? यहां पे ऑब्जर्वेशन इज नॉट ए आंसर. यहां पे यू हैव टू ट्रीट नो मैटर व्हाट साइज इट इज. लेस देन 2 सेंटीमीटर इन पेल्विस. देखो ये है पेल्विस, दिस इज द पेल्विस, ये, और ये है कैलिसेस. तो पहले हम कैलिस की बात करते हैं, हम पेल्विस की बात कर रहे हैं. लेस देन 2 सेंटीमीटर ESWL और RIRS. मोर देन 2 सेंटीमीटर PCNL. So the main indication of PCNL, which is percutaneous nephrotomy, is size. But there are certain contraindication of ESWL. Again, PCNL can be done in those contraindications. What is RIRS? RIRS stands for retrograde intrarenal surgery. क्या मतलब इसका? ये है किडनी, this is the pelvis, this is the ureter, and this is the bladder. The stone is in the ureter. How do you treat? Ureteroscope. तो हम ureteroscope का इस्तेमाल करते हैं. Can I take the ureteroscope to the kidney? No. Ureter is tortuous. I'll perforate the ureter. So what we do? We use flexible ureteroscope. Now I can take the ureteroscope to the kidney. Flexible. So I am going retrograde. नीचे से जा रहे हैं. Retrograde intrarenal surgery. Okay, so RIRS में we use flexible ureteroscope. Okay, and we have to break the stone. पूरा थोड़ी खींच के ला सकते हैं. So RIRS is only done for stone less than 2 centimeter. And how we break the stone? Using holmium YAG laser, HO YAG laser. So ESWL and RIRS are for stones which are less than 2 centimeter in pelvis. More than 2 centimeter, I'll go for PCNL. And in RIRS, we can break the stone using holmium YAG laser. ठीक है? Holmium YAG laser prostatectomy में भी use करते हैं. There also we use holmium YAG laser. Right? What are the contraindications of ESWL, which are not right? We are running short of time. मैं verbally बोल देता हूं. देखो, absolute contraindications are only 3. Number 1, pregnancy. Number 2, bleeding disorder. Number 3, distal obstruction. यहाँ कोई obstruction है तो हम जो obstruction relieve नहीं करेंगे, हम इसे तोड़ नहीं सकते. So, relative contraindications are children, size more than 2 centimeter, severe infection, uncontrolled hypertension, very hard stone, cysteine and calcium oxalate monohydrate are hard stone, calcified aortic aneurysm. All these are kind of relative contraindication. So, and one complication of lithotripsy, you break the stone, make it like a powder, it goes through the urine, but इसका टुकड़ा तो क्या छोटा रह गया, छोटा नहीं हुआ, टुकड़े रह गए. ये टुकड़े यूरेटर में आके इकट्ठा हो रहा. So all the broken fragments get stuck in ureter forming a line. This is called Steinstrasse. STEIN-STRASS. So Steinstrasse is a German word, means lane of a stone, road of a stone. Stone की एक road. So Steinstrasse is a German word having multiple fragment in ureter. This is called Steinstrasse, a complication of ESW. तो क्या करना चाहिए बड़े स्टोन को तोड़ने से पहले? Put a DJ stent. यहाँ पे एक स्टेंट डाल दो. Put a DJ stent, then break the stone. अब आप ब्रेक करोगे ना तो उसके अगर अटक भी गया, the stone gets stuck here, still patient will not have pain in urea क्योंकि स्टेंट पड़ा हुआ है ना, तो स्टेंट is protected. So this is basically the points you need to know. And what about the crystals shape in urine? Hexagonal, cysteine. Envelope shaped, calcium oxalate. Coffin lid, calcium phosphate. Stewite, phosphate, triple phosphate. So these are the shape. I'll show you. ये भी पूछा जाता है. See here. ये है oxalate, which is envelope shape. ये है ट्रिपल फॉस्फेट कॉफिन लिड अपीयरेंस. ये है सिस्टीन हेक्सागोनल. तो ये ऑक्सलेट स्टोन है, एनवेलप शेप. ये हेक्सागोनल सिस्टीन है और ये कॉफिन लिड फॉस्फेट है, ट्रिपल फॉस्फेट. और ये यूरिक एसिड है, नीडल शेप. तो ये भी पूछते हैं कभी कभी. सो मोस्ट कॉमन, सो दिस इज द सेलिएंट फीचर अबाउट renal stone. Okay, the important feature. Of course, as I told you, stone itself is a 45 minutes topic, so I cannot finish in 5 minutes. But ये important point आपको पता होना चाहिए. So, any doubt, any question you have? Okay. Surgery is conceptual. Surgery में रटने कुछ नहीं है, सब concept ही है इसमें. तो can you tell me the answer of this question? A 55-year-old lady presents with painless hematuria and swelling in the leg. And another good thing that I have observed in last 2 years, मैं FMGE को नहीं पढ़ाता था पहले क्योंकि बड़ा ज़्यादा प्रॉब्लम होती है समझाने में. उनकी थोड़ा बेसिक, डोंट टेक इट अदरवाइज, उनकी थोड़ा सा बेसिक नॉलेज कम होती थी, डिफिकल्ट टू. बट ऑफ लेट आई हैव रियलाइज्ड इन लास्ट फ्यू इयर्स दैट FMGE क्वेश्चन लेवल हैज गॉन अप एंड द स्टूडेंट लेवल आल्सो हैज गॉन अप. नाउ द स्टूडेंट्स आर एट पार विथ ऑलमोस्ट नीट. क्वेश्चन इज आल्सो एट पार विथ नीट. सो इट्स इजी फॉर मी टू टीच यू आल्सो. So, yes, this is radical nephrectomy, which is renal cell cancer. Cytology is positive. Let's understand the points of renal cell cancer. क्या features renal cell cancer में हमें पता होने चाहिए, ठीक है? देखो, renal cell cancer is adenocarcinoma. And the risk factor are VHL, von Hippel-Lindau disease, chromosome 3p. There are other risk factors. I'm only telling the very, very important points. The types are clear cell. This is the most common type, and VHL, we only get clear cell. Only clear, no other type. Second type is clear cell type is the most common, 70%. Second is chromophil, 15%. Third is chromophobe, 5%, and collecting duct. Right. Collecting duct has poor prognosis, also called Bellini duct cancer. So, clear cell is the most common type, mainly seen in VHL, 70%. Chromophobe, PHOBE, it has best prognosis. This is another MCQ. Chromophobe having best prognosis, okay? So, this is the basic. Now, the classical presentation of renal cell cancer is late triad, which is hematuria, pain, and lump. This is the triad for renal cell cancer. Hematuria. For Wilms tumor, which you get in children, nephroblastoma, it is lump, fever, and hematuria. So, for Wilms tumor, lump, fever, hematuria is the triad, while in renal cell cancer, pain, lump, and hematuria is the triad. There is fever here and there is pain here. That's the only difference. The investigation of choice is CECT, no biopsy. No FNAC. This is one of the tumor where biopsy and FNACs are contraindicated. Staging, you have to remember. Please try to remember the staging. Treatment is surgery. No radio, no chemo. And in surgery, we do radical nephrectomy. Yeah, hypertension can be there, but that's not a part of triad. Hypertension due to renin, that's a part of WHGR is for Wilms tumor, not for here. WHGR and Beckwith-Weidman syndrome for Wilms tumor, WT1 and WT2G. So, radical. What is the point we need to know radical? Approach is transperitoneal, anterior approach, transeptum, not from the flank. Side से करते हैं kidney surgery, यहाँ नहीं करते, सामने से करते हैं. Number 2, so transperitoneal. Number 2, first you apply renal collar on renal vein, then ligate renal artery first, then ligate renal vein. I'll repeat. सबसे पहले रीनल कॉलर लगाते हैं, हाँ, क्रोमोसोम 11p, शॉर्ट आर्म ऑफ क्रोमोसोम 11, बैंड 13, ये WT1 के लिए होता है, वेल्स ट्यूमर के लिए। अभी हम रीनल सेल कैंसर की बात कर रहे हैं। तो रीनल कॉलर यू अप्लाई ऑन द रीनल वेन, फर्स्ट लाइगेट द आर्टरी, देन लाइगेट द वेन। सो ट्रांसपेरिटोनियल अप्रोच होगी, आप रीनल कॉलर लगाएंगे वेन पे, फिर आर्टरी लाइगेट करेंगे, फिर वेन लाइगेट करेंगे। नाउ यू रिमूव व्हाट ऑल यू रिमूव, क्या निकालेंगे रीनल सेल कैंसर रेडिकलेक्टोमी में? वी रिमूव होल किडनी with complete perinephric fat along with the Gerota's fascia. You are not allowed to open the Gerota's fascia in renal cell cancer retinopathy. Pure Gerota's fascia, the fascia of the kidney has two capsules, its own capsule and Gerota's fascia second capsule. Pura nikalenge with the perinephric fat. And ureter. How much ureter? Complete abdominal ureter. एब्डोमिनल यूरेटर का मतलब टिल पेल्विक ब्रिम, या आप कह सकते हो टिल पेल्विक ब्रिम, या टिल बाइफर्केशन ऑफ कॉमन आइलियक. सो वी, अरे पूरा ही गायब हो गया, कोई बात नहीं, चलो. सो वी रिमूव किडनी, आई राइट इट हियर, इस पे लिख देता हूं. सो वी इन रेडिकल इफेक्टमी वी रिमूव किडनी, वी रिमूव पेरीनेफ्रिक फैट, we remove intact gerotas, and we remove ureter. How much ureter? Complete abdominal ureter, which means till pelvic brim or bifurcation of common ileum. What about node and adrenal? Yes, they can be removed, but these are optional. These are not part of radical nephrectomy. Adrenal is removed when the tumor is more than 4 centimeter or it's at the upper pole. So adrenal can be included in this specimen. Node can be removed only for staging purpose. Node has no role in survival, in prognosis. नोड निकालने से प्रोग्नोसिस पे कोई फर्क नहीं पड़ेगा. नोड आप छोड़ भी सकते हैं, और अगर आप निकाल रहे हैं तो स्टेजिंग के लिए निकाल रहे हैं. और एडनल भी निकालेंगे, यस, अगर अपर पोल पे मोर देन 4. व्हाट अबाउट पार्शियल नेफ्रेक्टमी? कैन वी डू पार्शियल? यस, वी कैन डू. व्हेन इट इज लेस देन 4 सेंटीमीटर बाइलेटरल किडनी ट्यूमर या सॉलिटरी किडनी, एक ही किडनी काम कर रही है, उसमें ट्यूमर हो गया, ये तो आप बिल्कुल कर सकते हैं. अप टू 7 सेंटीमीटर इज रिलेटिव इंडिकेशन. वी कैन इवन डू पार्शियल नेफ्रेक्टमी अप टू 7, अप टू 4 डेफिनेटली वी कैन डू. सो पार्शियल नेफ्रेक्टमी कैन बी डन फॉर ट्यूमर्स लेस देन 4 सेंटीमीटर, इट्स बायलेटरल ट्यूमर्स और इट्स सॉलिटरी किडनी हैविंग ट्यूमर. वन किडनी काम करे, उसी में ट्यूमर हो गया तो पार्शियल भी करेंगे. लेस देन 4 वी कैन डेफिनेटली डू, लेस देन 7 रिलेटिव. सो दीज आर द salient point you need to know about renal cell cancer. So, right answer is D. Any question? Chromosome 3p, short arm of clear cell. So, next question. Testicular tumor मैंने ऑब्जर्व करा है कि FMGE में काफी पूछा जाता है. So, can you answer this question? Yes. So, a 30-year-old male presents with a scrotal mass. So, young is scrotal mass, number 1. Number 2, LDH is high, but these two are normal. Yes. The answer is seminoma. Again, you all are correct. Knox, Saf, Amit, Sheikh, कुशल, गुड, वेरी गुड. आप सभी सही, शोएब, सारे सही हो. देखो मैं आपको टेस्टिकुलर ट्यूमर का थोड़ा सा कंसेप्ट बता देता हूं इन 5 मिनट्स. देखो, टेस्टिस ट्यूमर कैंसर आर डिवाइडेड इन 2 ग्रुप. 95% we have germ cell tumor. 5% we have non-germ cell tumor. In non-germ cell, mainly Leydig cell and Sertoli cell. Leydig cell tumor and Sertoli cell. Okay. So non-germ cell is only 5%, having 2 main type, Leydig and Sertoli cell. These are very rare, only 5%, not normally asked. But Leydig cell has an inclusion body called Rinke crystal. This is unlikely to become a question in FMGE or EINK. But this is a question of this very year. Last month, AIIMS, they showed an image Rinke crystal and asked where you get this. So Rinke crystal is the inclusion body in Leydig cell tumor. So only point you remember this, though unlikely to be asked in FMGE. Germ cell 95%. This is further subdivided into seminoma and non-seminoma. Seminoma and non-seminoma. So how you classify testicular tumor? Germ cell and non-germ cell. Germ cell 95%, non-germ cell only 5%. Non-germ cell are Leydig and Sertoli cell. Germ cell, seminoma, non-seminoma. Non-seminoma are teratoma, choriocarcinoma, embryonal cell tumor, and yolk sac tumor. Yolk sac is also called endodermal sinus tumor. So teratoma, choriocarcinoma, embryonal cell cancer, yolk sac tumor, all these are non-seminoma. Now some one-liners. What is the most common testicular tumor? Generally we call it mixed, but in mixed maximum is seminoma. What age? Young age, 15 to 35 or less than 40 years. So normally young age, it's not an old age cancer. So most common seminoma. What about most common old age cancer? Lymphoma. There is a type called spermatocytic seminoma. Spermatocytic seminoma. That's also seen in old age. A rare type spermatocytic 10% seminoma, old age. Lymphoma. What about within 4-5 years? Children, young children. Most common testicular tumor, young children means say 3-4 years. Yolk sac tumor. What about within 6 months? Most common tumor? Granulosa cell tumor. Granulosa cell tumor. What about puberty, second decade? It's about 10 to 15 years. Teratoma. What about undescended testes? Which cancer? Undescended seminoma. What if we bring the testes down in undescended testes? So after orchidopexy has been done, orchiopexy has been done in undescended, then embryonal cell cancer. Embryonal cell. And what about hermaphrodite? Hermaphrodite. Intersex, then dysgerminoma. So these are one-liners for and worst prognosis. Worst prognosis in testicular tumor. A type of choriocarcinoma called hurricane tumor. Hurricane tumor. Hurricane cancer. So hurricane tumor is a type of choriocarcinoma which has the worst prognosis, and choriocarcinoma has one more property, blood-borne secondaries. As you know, testicular tumor has a property of lymph node secondaries. First para-aortic node, choriocarcinoma, blood-borne secondary. So I'll repeat what I said. Most common testicular tumor is seminoma, young age. Most common testicular tumor in old age, lymphoma. In young children, within 4-5 years, yolk sac tumor. Within 6 months, granular cell tumor most common. In second decade, early second decade of puberty, teratoma. Undescended testes, again seminoma. After orchiopexy, undescended testes, embryonal cell cancer. In intersex, most common is dysgerminoma. and worst prognosis is choriocarcinoma, hurricane tumor. Okay, so these are one-liners. Remember, FNAC or biopsy is strongly contraindicated. No scrotal procedure should be done. What investigation you order? We order ultrasound, CT abdomen, and if you have, you can order PET CT or at least X-ray chest. Why CT abdomen? Because the para-aortic lymph nodes are involved, not the inguinal, not the pelvic. Testis drains to para-aortic node, that's why CT abdomen. What tumor markers? Tumor marker number 1, alpha fetoprotein. Never high in seminoma or choriocarcinoma. In this question, AFP is normal. If AFP is high, it is neither seminoma nor choriocarcinoma. In these two tumors, it's never high. It is mainly high in yolk sac tumor, but in teratoma cell cancer, it can be high also. Second is beta HCG. This is for choriocarcinoma, 100% case. And in seminoma, can beta HCG be high? Yes, 10%, because it comes from syncytial trophoblast, and 10% seminoma has syncytial trophoblast, so of course it can be high, only in 10%. So beta HCG is a marker for, it's never high in yolk sac tumor. Beta HCG high means it cannot be yolk sac. So beta HCG high basically choriocarcinoma, rarely seminoma. For seminoma, LDH is the main marker. Another one is PLAP, placental alkaline phosphatase. For seminoma and non-seminoma, first step in treatment is high inguinal orchidectomy. High inguinal. The orchidectomy is done from the inguinal root, not from the scrotum. I told you earlier, scrotal approach is contraindicated. Then for seminoma, early stage, give radiotherapy to the retroperitoneum inverted Y field around 2,000 to 3,000 rats for late stage chemotherapy. Bleomycin, cisplatin, etoposide. Generally, this is what we prefer. Bleomycin, cisplatin. So for seminoma, early stage, not radiotherapy to the scrotum, to the inguinal area, no, to the abdomen, to the node, lymph node. And for non-seminoma, early stage, RPLND, retroperitoneal lymph node dissection, late stage chemotherapy. So early stage RPLND, retroperitoneal lymph node dissection, late stage chemotherapy. So I'll just repeat what I said about cancer, testicular cancer. I'll repeat it once more. Testicular cancer, which is a common cancer in young age, divided in germ cell tumor, non-germ cell tumor. Non-germ cell tumor only 5% Sertoli and Leydig cell. One more inclusion body I'll tell you. So Sertoli cell and Leydig cell are non-germ cell. Leydig cell has Vinky crystal. Remember, yolk sac has a inclusion body called Schiller-Duval body. SCHILLER. Schiller-Duval bodies. ये भी पूछते हैं कि Schiller-Duval body testicular tumor में किसमें मिलता है? Yolk sac tumor में. So Schiller-Duval body. Okay. And approach wise, only order ultrasound scrotum, CT abdomen to see lymph node, and PET or X-ray to see metastasis chest if you have, and tumor marker. So this is about testicular tumor concept in 10 minutes or rather 5 minutes. So the LDH is high, but beta HCG and this is normal, then this ought to be seminoma. Okay. So any doubt, any question here? And one more marker for seminoma is PLAP, placental alkaline phosphatase. So any question? I'm not sure whether you can see this video again. If you can see this, you can make notes. I don't have time to go very slow and explain everything, but you can revise it and see. Another 2-3 questions, another 5-10 minutes, and that's it. So, what is the treatment for muscle invasive bladder cancer? Can you see this video again? Is it possible? I don't know. I mean, I'm not sure. Right. So, no. Oh, that's a shame. Anyway, I think I've made some concept clear. So can you tell me the answer of this? Okay. See, ब्लैडर कैंसर में क्या है, हाँ अगर देख सकते हो फिर तो देख के दोबारा से आप नोट्स वगैरह बना लेना ना, बिकॉज फर्स्टली आई एम गोइंग लिटिल फास्ट, limited time, secondly my writing is not very legible, so of course it's a problem, but anyway I think you can understand what I'm saying. देखो ब्लैडर कैंसर में क्या है ना कि 90% is transitional cell cancer, and the main causes are smoking, maybe radiation, dye, certain dicyclophosphamide drug, etc. 5% is squamous cell, schistosomiasis, smoking, etc. But smoking is more for TCs, transversal, and 2 to 3% adenocarcinoma, which is not common in bladder. Adenocarcinoma in patent urachus, ectopia vesicae. So the first thing you do is cystoscopy and biopsy. And this is the bladder, mucosa and muscle. If muscle is invaded, we call it invasive. Then the treatment is radical cystectomy. But in case it is carcinoma in situ or T1, muscle is not invaded, then we resect the tumor by cystoscopy, transurethral resection of tumor followed by intravesical BCG. So superficial bladder tumors are treated by, first you do surgery, resect by endoscopy and go for BCG. But once it's invasive, then you go for radical cystectomy, where you remove the bladder, the prostate and prostatic urethra as well. So the answer is radical cystectomy, which will include prostate as well. So once neoadjuvant chemotherapy first is not very helpful, and chemotherapy, when we give, we prefer cisplatin based chemotherapy, not mitomycin C. Mitomycin C is preferred for intravesical. So I'll repeat: bladder cancer, superficial TIS T1, do endoscopic surgery followed by intravesical BCG. If it's muscle invasive or lymph node involved, radical cystectomy. Very simple approach. A 65-year-old patient underwent TURP for BPH. Biopsy revealed presence of carcinoma in prostate specimen, and there is metastasis as well. How do you treat this patient? So can you tell me the answer of this question? देखो, how do you treat prostate cancer? TIS, T1A and B. If the Gleason score is less than 7 and age is more than 70, just observation. So when the prostate cancer, the very early stage cancer, Gleason score is the score of the grading of the prostate cancer, and age old, observation. But for all T1, T2, if the Gleason score is more than 7 or age less than 70, go for either radical prostatectomy or radiotherapy. No chemo, radiotherapy. So prostate is chemo radio responsive. So radiotherapy and radical prostatectomy, both options are there when you have to operate. But once it's T4 or stage 4 or metastasis, then you have hormone therapy. So out of these 4, which hormone you give for prostate cancer? Of course, leuprolide. Leuprolide, goserolin. You have different LHRH antagonist and agonist. So the best answer. with metastasis. For bone, I can go for radiotherapy or strontium-90 interstitial radiotherapy, but best is hormone therapy. So all metastatic prostate cancer is treated by local symptomatic relief by TURP followed by hormone therapy, which is earlier we used to do orchidectomy. Now we are giving anti-androgens and LHRH agonist. So leuprolide is the best answer, hormone therapy. I'll repeat. If I give, this is a commonly asked question. A BPH question, you do TURP for BPH, benign. And now there's a cancer. And cancer is confined to prostate. No other metastasis, nothing. Age 75 years, Gleason score 6. What you do? Observation. So Gleason score low and no metastasis, early stage cancer, age more than 70, observation. Age less than 70 or Gleason score high, then you can go for radical prostatectomy or radiotherapy. Both are comparable. But when there is metastasis, then best treatment is hormone therapy. Just in one line prostate cancer. Of course, it's not as simple as I'm telling you, but just to help you in doing MCQ. A 14-year-old boy presents with absent left testis in scrotum. This I will wait for you to answer. This is a very conceptual question, very important question, and very frequently asked. ये आपके FMGE में इस तरह के सवाल बहुत आते हैं. So can you tell me the answer of this? I'll wait for 1 minute for you to answer. This is an important concept, very important. Yes, good. देखो, this is internal ring, external ring, and the testis comes down in the scrotum in the normal position. If you find testis in its normal path, but not in the scrotum, anywhere in the normal path, this is called undescended testis in the normal path. And the most common site of undescended testis is inguinal canal. But if you find testis deviated from its normal path, then you call it ectopic testis. The most common site of ectopic testis is superficial perineal pouch or superficial perineal space, which is a question here. So it's in the superficial inguinal pouch, that is ectopic testis. So undescended, ectopic, what is the difference? Undescended, it's a normal path of descent, ectopic away from it. Number 2, what is the first thing you do? You examine and go for ultrasound. You find the testis, you bring the testis down. What is the ideal time? 6 months to 1 year. Orchidopexy. What if you find non-palpable testis, pressures in the abdomen? अब क्या करेंगे? So don't find in ultrasound. Now you go for laparoscopy. Laparoscopy. Non-palpable testis, you examine under GA, still you don't find, do laparoscopy. In laparoscopy, it's a blind ending testicular artery. The artery is not supplying any tissue, no tissue, it's ending blindly. Testicular artery आपको दिख रही है और खत्म हो जा रही है जाकर के. This is agenesis of testis. You cannot do anything. It is anorchia, congenital abscess. इस पे क्या सवाल बनते हैं? What is the best investigation to see anorchia, agenesis? Laparoscopy. In laparoscopy, you find blind ending artery. What you do? Nothing. Abandon the procedure. अब आप कुछ नहीं कर सकते हो. दूसरी पॉसिबिलिटी है testicular artery entering into internal ring, means testis is in canal. तो यहां से आपने लैप्रोस्कोप डाला अम्बलाइकस से और आपको आर्टरी इंग्वाइनल कनाल में आती दिखाई दे रही है. इसका मतलब कि टेस्टिस इंग्वाइनल कनाल में है. Bring the testis down from outside like a normal laparoscopy, like a normal orchiopexy. So testis in inguinal canal. I'll repeat. अगर आपको absent artery दिखाई दे रही है, means absent testis. अगर आपको आर्टरी कनाल में जाती दिखाई दे रही मींस टेस्टिस एंड व्हाट इफ यू फाइंड द टेस्टिस हाई अप, टेस्टिस यहां पे पड़ी हुई है, you find that the artery is going here and supplying a testis which is totally intra-abdominal. ये internal ring के ऊपर पड़ी है. I cannot bring the testis down because artery is small. So if it is a high testis in the retroperitoneum cannot be brought down, तब हम 2 स्टेप प्रोसीजर करते हैं. इसको कहते हैं स्टीफन फाउलर टेक्निक. When we do Stephen Fowler technique in undescended testis in laparoscopy, Stephen, S-T-E-P-H-E-N, F-O-W-L-E-R, Stephen Fowler. ये हम तब करते हैं when the testis is in the inguinal, above the internal ring in the retroperitoneum, you cannot bring the testis down. भाई ये abdomen है और आपने laparoscopy यहां से करी और testis आपको यहां पे मिल रही है और ये testis artery is coming from the aorta, an internal ring here, external ring here, and this is the. So how to bring the testis down? The artery is small. तो आप आर्टरी को लाइगेट करके काट दे दो, कट द टेस्टा आर्टरी, लेट द कोलेटर डेवलप, इन सेकंड स्टेज में टेस्टिस को नीचे लाया. इसको कहते हैं स्टीफन फॉलर टेक्निक. सो स्टीफन फॉलर टेक्निक इज डन व्हेन द टेस्टिस इन द एब्डोमेन, शॉर्ट टेस्टा आर्टरी अबव द इंटरनल रिंग, यू कैन डू दिस. सो दिस इज द अप्रोच ऑफ अनडिसेंड टेस्टिस. इन टाइम ऑफ सर्जरी 6 months to 1 year, आइडियल टाइम 6 months. सो दिस इज अबाउट अनडिसेंडेंस. आई विल जस्ट रिपीट व्हाट आई हैव सेड. Undescended testis basically is when the testis is in the normal path of descent. Ectopic testis went away from the normal path of descent. And time of surgery is 6 months. And undescended testis, we don't bring it down. Leydig cell may persist, तो कोई प्रॉब्लम नहीं है टेस्टोस्टेरोन बनने में, बट जर्म सेल नहीं बनते और इनफर्टिलिटी होगी, बाद में कैंसर का भी रिस्क होता है. ओके, फाइनली last question. Which of the following is true about pathology shown in the image given below? And I'm sure आप इसको identify कर रहे होगे. ये एक important photo है. This is Fournier's gangrene. Fournier's gangrene. F-O-U-R-N-I-E-R. Fournier's gangrene. Yes, Saf, you are right. Testis is spared. Fournier's gangrene की खास बात क्या है? This is a synergistic infection. Yes, Mohit, it's Fournier's gangrene and this is synergistic infection. Synergistic का क्या मतलब? Aerobic and anaerobic both bacteria, staph and microaerophilic streptococci, E. coli, bacteroides. So both, aerobic and anaerobic both. So it's a very aggressive condition. Very rapidly patient develops gangrene, spreads very rapidly. Patient will have septicemia if you don't operate. But testis is always if spared because tunica albuginea is a barrier. Around the testis we have tunica albuginea that acts like a barrier. So testis is always spared. Even in surgery you see we leave both testis hanging. In the past, it was called shameless exposure of testis. Thus, orchidectomy was not done. We can implant the testis in the thigh later on if required, but no orchidectomy because in Fournier's gangrene, the testis blood supply comes from the abdomen to the testicular artery, so it's not involved. Okay, so testis is not involved. It's caused by streptococci, that's okay, but not only strepto. It's along with strepto and staph or E. coli, synergistic, multiple bacteria, polymicrobial infection. So surgery is the main treatment, excision and antibiotic. But orchidectomy is not done. Testis is preserved in this pathology, okay? So D is the true. So this is about 25 questions. I have chosen some important topic. Of course, in 1-2 hours, you can only discuss this much. So any doubt, any query, any other question you have, any surgery problem you have, feel free to ask. I'll wait for 2 minutes and that's it for today. All the best to all of you. कोई और क्वेश्चन, कोई भी सवाल, कोई भी डाउट आप पूछना चाहते हैं? सो ओके, सो एनी क्वेश्चन बच्चों? चलो ठीक है फिर। Blood testis barrier Shoaib is formed by Sertoli cell. Blood testis barrier is formed. Sertoli cell has many functions. One is to produce inhibin, which has a feedback on FSH. Second is blood testis barrier. Third is to provide nutrition and support to germ cell. And fourth is to produce mullerian inhibiting substance in fetus. ईसोफेजियल अट्रेसिया में ऐसी कोई बात नहीं है, ऊपर वाला एंड बंद होता है, नीचे वाला एंड बंद होता है. दिस इज कॉल्ड ईसोफेजियल अट्रेसिया. द चाइल्ड वी कैन नॉट swallow anything, so he'll have regurgitation and drooling of saliva, usually operated by Fokker operation. F-O-K-E-R, Fokker. This is called type A tracheocerebral fistula. ठीक है, चलो, गुड नाइट and all the best to all of you. So I'm going to log out now.